The procedure will be that I'll make an opening statement, Senator Leahy will, and then we'll go to the order that we have established as you see people sitting at the table there. I'll introduce the senators, and Senator Leahy's going to introduce the governor. America is experiencing a historic epidemic of drug overdose deaths. Over 47,000 died from overdoses in 2014. That's an all-time high. To put this in perspective, it's more deaths that resulted from either car crashes or gun violence. Addiction to opioids, primarily prescription painkillers, and heroin is driving this epidemic. It is destroying lives, families, and the fabric of entire communities. It's something that I'm hearing about in Iowa. Of course, other parts of the country have been hit even harder. At today's hearing, the committee will learn more about this terrible epidemic, what's being done to address it, and how Congress can help. The committee looks forward to learning more about the Comprehensive Addiction and Recovery Act, which is the result of the leaderships of Senators Whitehouse, Portman, Klobuchar, and Ayotte on this very important issue. Over the last 20 years or so, doctors have increasingly prescribed opioids to help their patients manage pain. For many, these medicines have been the answer to their prayers. But for others, they have led to a nightmare of addiction. The New England Journal of Medicine estimated that over 10 million persons reported abusing prescription opioids at some point, 2014. The emergency room visits involving the misuse of the prescription opioids increased over 150% between 2004 and 2011. Treatment admissions linked to them more than quadrupled between 2002, 10 years later, 2012. The use of heroin has also spiked sharply. The National Survey on Drug Use and Health reports over 900,000 Americans used heroin in 2014, nearly a 35% increase from the previous year. Heroin deaths more than tripled between 2010 and 14. In 2007, only 8% of state and local law enforcement officials across the country identified heroin as the greatest drug threat. Now, this year, or last year, that number rose to 38% more than any other drug. According to numerous studies, prescription opioids addiction is a strong risk factor for heroin addiction. In some cases, those addicted to painkillers turn to heroin to get a similar high because recently it's become cheaper and more easily available. Now, very important question. Why has cheap heroin begun flooding into our communities? Well, Mexican cartels are expanding into new territory because the administration hasn't secured the border. Indeed, heroin seizures at the border have more than doubled since 2010. The Senate Caucus on International Narcotics Control, joined by our colleague Senator Ayotte, sought accountability for this alarming development at a hearing in November. So this is a complex crisis requiring a multifaceted solution. The first and most important part must be prevention to head off addiction before it can even begin. Prevention includes educating the public about the dangers of these substances, including through the important work of anti-drug coalitions. It also includes educating doctors, taking a hard look at perverse incentives that may lead to over-prescribing. For example, a few weeks ago, Senator Feinstein, Ayotte, and I wrote to HHS to seek a progress report on a federal review exploring whether patient satisfaction surveys linked to higher Medicare payments actually encourage doctors to prescribe opioids. Many people who abuse prescription drugs get them from friends or relatives, so prevention always also involves support for initiatives that allow patients to safely dispose of old or unused medications. So that brings me back to something I was involved in to help start these take-back programs by working with Senators Klobuchar and Cornyn in 2010 to pass a Secure and Responsible Drug Disposal Act. And I was pleased when DEA Acting Administrator Rosenberg voiced his support for them very recently. At the same time, it's concerning that this administration is muddling prevention efforts by sending mixed signals to young people about the danger of addiction to marijuana. The president has even excused smoking marijuana as just another bad habit, and the Department of Justice continues to decline enforcing our federal drug laws in this area. But young people don't need increasing access to another potential pathway to addiction. According to CDC report, a person who is addicted to marijuana is 3 times more likely to be addicted to heroin. Another part of the solution needs to include better treatment options for those who become addicted. The use of medication-assisted treatment appears to show promise. So along that line, overdose deaths may be reduced by the more widespread use of naloxone, drug proven highly effective in reversing overdoses. And finally, law enforcement will play a very critical role. We can't arrest our way out of this epidemic, but we can continue to crack down on unlawful prescribing practices, enforce our border with Mexico, and target the violent cartels that are trafficking heroin in this country. So I get back to something else a member of this committee and I have been involved in. Senator Feinstein and I introduced the Transnational Drug Trafficking Act 2015. Our bill would make it easier for the Department of Justice to prosecute cartels who harm our communities from abroad by trafficking heroin, other drugs, and precursor chemicals, the ultimate delivery for ultimate delivery here in the United States. In October, our bill passed the Senate for the 3rd straight Congress by unanimous consent, but hasn't found success in the House. So it's critical that the representatives finally pass this legislation, which will help protect our communities from transnational drug trafficking threats. So I'm finished. I welcome our guests, and I'll introduce them. I now turn to Senator Leahy.
Well, thank you very, very much, Mr. Chairman. I think when you look around this committee, Republicans and Democrats from representing all parts of the country, we know that in our communities, whether they're urban or local, no matter what their size, they're grappling with the tragic effects of the epidemic of heroin and prescription opioid abuse. We've all seen the statistics. I'll tell you one thing about the dramatic rise in overdose deaths, particularly among young people. But go behind the numbers, as I have, Governor Shumlin in our state has, Eric Miller, our U.S. Attorney, has. And behind the numbers, you see the human impact of this epidemic. Families trying to find and afford treatment for a loved one hooked on painkillers. Children neglected or left behind by an addicted parent. Victims of crime fueled by addiction. Law enforcement community officials overwhelmed by the flood of opioids and cheap heroin. My wife is a retired registered nurse. She and I have sat around some of the kitchen tables in Vermont. And our governor would know some of these locations. Some of them are very affluent areas, and some are very poor areas. But the stories we have heard from families and parents, and we've usually gone there just ourselves, no press, nobody else, just wanted to talk to these people. We've had a couple of times we've driven away, we were both in tears, what we've heard. These are human stories, go way beyond the statistics. So it's not a question of whether there is an epidemic. The question is, what do we do about it? Like many other states, we've not been immune to the scourge in Vermont. But in following what we normally do in Vermont, we've rallied together to tackle the problem head on through community-based and comprehensive strategies. That makes me proud to be a Vermonter. We heard testimony about a number of these innovative approaches during a series of field hearings I convened during the past several years in Vermont. In one city, in Rutland, they went to the mayor, a strong Republican, I might say, and they said, do we want to talk about this in our city? He said, we darn well want to talk about it. And we had to keep changing the venue because more and more people wanted to come. We had city officials, their project vision brought city officials, law enforcement, residents, and we heard from all of them, knowing that this is not just a law enforcement, it's not just a medical profession. We had the faith community, parents, educators, they're all in it together. The Boys and Girls Clubs throughout Vermont are working with schools and public health officials to help children who are swept up by this. In all of my conversations, though, with Vermonters, from law enforcement down through, one thing is clear. We cannot arrest or jail our way out of this problem. We've lost the war on drugs because we relied primarily on unnecessarily harsh sentencing laws. We can't repeat these mistakes of the past. We've also got to start working on the demand. We could close everything. Let's assume we could close everything coming from Mexico. If we have demand in this country, it will come from somewhere else. So long as we have people who spend the money, who want to buy the opioids, who want to buy the heroin, it will come here. I don't care which border we close, it will come here. So we've got to stop the demand. We have to identify and support effective prevention, treatment, and recovery programs, and we can't just pay lip service to our communities. After the field hearing I convened in Rutland, I advocated for a new federal grant program to fund expanded treatment options for heroin and opioid abuse. I worked to get more federal funding to law enforcement to go after drug traffickers. In Vermont, we've seen a 65% increase in the number of Vermonters getting treatment for their addiction in the last couple of years, and Governor, I thank you for that. It's great progress, but we know on any given day there are hundreds more who find themselves on waiting lists. Other patients in rural corners of my state travel hours just to get their medication. So I'm seeing Senator Shaheen here. I've co-sponsored her emergency supplemental appropriations bill to fund additional public health outreach and treatment and recovery and law enforcement efforts. I'm proud to co-sponsor the Comprehensive Addiction Recovery Act. I hope the committee will report that bill soon. We can talk about it, we can have bills, we can have resolutions. Let's spend the money. Spend the money for things outside our country, let's spend the money for things in our country. This is a great danger, and we should spend money on it. So I will close with thanking Governor Shumlin. He's been a national, local leader on this issue. And when a lot of people wanted to pretend we didn't have the problem, the governor gave in his State of the State address in the past, instead of saying everything's going great, we've got all this, as most governors do, he talked about this problem. That was his whole issue. And boy, the reaction around our state and around the country was saying, it's about time. It's about time somebody speaks up. So, Senator Grassley, I thank you for convening this hearing, but we've got to find comprehensive and enduring solutions. Federal government will do its part to provide the resources and support necessary. That's important. But we have to act. We're not going to rest our way out of this. Everybody in law enforcement knows that. We're not going to do it simply by saying, let's close a source from one country because it will come from another country. We've got to attack and work and do all the comprehensive programs, the faith community, the educators, law enforcement, parents, medical facilities to stop the demand. Until you stop the demand, we'll always have the problem. Thank you.
Why don't you continue your introduction of the governor if there's anything else you want to say at this point?
Well, thank you.
Or do you want to go ahead?
No, go ahead. Now, I will introduce him. No.
Obviously, when you're introducing colleagues like I'm doing, you know an awful lot about them that ought to be said, but you have to kind of keep.
Can't do that.
Short. So, but I can say all of them are extremely dedicated to fighting the opioid epidemic sweeping their communities. And I'm grateful that they're all interested in this and that they've been buttonholing me for a long time to move along with this hearing. And I think from initial discussions with members of this colleague, we feel like both from a cost standpoint and from a substance standpoint that we might be able to move ahead. At least I hope that's the outcome after I talk to all my members. Our first witness is Senator Ayotte, New Hampshire. She is co-author and original co-sponsor of this bill, S-524, the Comprehensive Addiction Recovery Act. She's a former prosecutor and attorney general who is one of the leading voices in Congress seeking solutions to opioid epidemic. Our second witness, Senator Shaheen, also from New Hampshire. She is also co-sponsor of CARA and have been highly effective leader on the issue. New Hampshire is fortunate, obviously, to have two senators working across the aisle on this very important crisis issue. Next, Senator Rob Portman from Ohio, co-author and lead Republican sponsor of CARA. He's worked tirelessly in bringing awareness to this epidemic throughout the state and has long been a champion of the anti-drug initiative, including the Drug-Free Community Act, and also probably 20 years ago came to my state to help me with a nonprofit organization that I started in my state as well. So our relationship on this issue goes back a long, long time. And now it's your opportunity on the governor.
But Peter Shumlin has served as governor of Vermont since 2010. He's a small business owner. He's a public servant, father of two from Putney, Vermont, two wonderful young women. He's a committed entrepreneur. He's a longtime co-director, along with his brother, of Putney Student Travel and National Geographic Student Expeditions. Incidentally, Governor, your brother told me at the opening of the session he is counting the days to get you back there in the company. It's a company that sends students on educational programs and service projects across the globe, partner in several real estate companies that provide housing and commercial space. Southeast Vermont, I've known him forever, it seems, his career in public service began 30 years ago. At the age of 24, he was elected to serve on the town select board. In 1990, Governor Madeline Kunin appointed him to fill an empty seat in the Vermont House of Representatives. He served there 3 years. He then served for 8 years in the Vermont Senate, where he's elected by his colleagues, Republicans and Democrats alike, to lead the Senate as President pro tem. He's the 81st governor of Vermont and is a very close personal friend.
Thank you all very much, and we'll do it in the order that I introduce you. So it'd be Senator Ayotte, Senator Shaheen, Senator Portman, and then Governor Shumlin. Proceed, please.
Thank you, Chairman Grassley, Ranking Member Leahy, members of this committee. I am so pleased that you're having this hearing today because this is the most urgent public health and safety crisis facing my home state of New Hampshire. And having served as the Attorney General of our state, I can assure you I have never seen anything like this in terms of the epidemic that we are facing. So the timing of this hearing could not be more important. I'm very honored to be here with my colleague, Senator Shaheen. In the fall, we held a hearing, a field hearing of the Homeland Security Committee, and heard from people in New Hampshire, but we also heard from Director Botticelli of the Office of National Drug Policy, who has been a very strong partner with New Hampshire. So I appreciate the work that Senator Shaheen and I have done together on this issue for our state. I'm very honored to be here with Governor Shumlin, who has been a real leader for Vermont in our neighboring state and has had such a keen focus on this important issue. Finally, I want to thank my colleague, Senator Portman, who has been a leader on the Comprehensive Addiction and Recovery Act. But he's got a long history with this because he started his own anti-drug coalition in Ohio. He's also led the effort when he was in the House of Representatives to pass the Drug-Free Communities Act, which spawned coalitions across this country. And now, working with Senators Klobuchar and Whitehouse, I was proud in September of 2014 to introduce the Comprehensive Addiction and Recovery Act. I want to thank the members of this committee who are sponsoring this act, certainly Ranking Member Leahy, Senator Hatch, I know Senators Blumenthal, and I also want to thank Senator Donnelly for the work that we've done on legislation together on this important issue. Today you will hear in the third panel from the Police Chief Nick Willard of our largest city, Manchester, New Hampshire. He is going to talk to you about the epidemic facing our state, how we can address this together, both law enforcement, working with those in prevention, treatment, and recovery. And I had the privilege of doing a ride-along with the Manchester Police Department. And I also did one with the Manchester Fire Department. I was there an hour and a half. We went to 2 heroin overdoses within an hour and a half. And I can assure you this is hitting every family in some way in New Hampshire. I watched our first responders bring people back to life with Narcan, but for them being there and having this life-saving drug, they would have died. And it's just really struck me how devastating this is, because one of the cases that I went to, there was a baby in a crib in the corner. And so when we think about this, this is not just the impact of those who are struggling with addiction. It's the impact on all of our quality of lives and, of course, on the future for our children. In New Hampshire, in 2014, we had 320 drug overdose deaths. That was a 60% increase from the year before. This year, our chief medical examiner tells us that 385, 148 of those deaths are also attributed to a devastating drug called fentanyl, which DEA tells us is 50 times more powerful than heroin. And that is an issue I believe needs to be addressed by this committee as well. Solving this crisis requires a holistic approach. And the Comprehensive Addiction and Recovery Act that so many members, and I really appreciate the leadership on this committee on this act, is critical, I believe. We brought together over 120 stakeholder groups around the country to put this legislation together, those who are on the front line in every aspect. It has the endorsement of the National District of Attorneys Association, the major County Sheriff's Association, the Community Anti-Drug Coalitions of America, and the National Associations of Attorney General. I would note, by the way, my Attorney General from New Hampshire has endorsed it, the Iowa Attorney General has endorsed it, the Vermont Attorney General has endorsed it, and many of the other attorneys of your Attorneys Generals have said, please pass this legislation. It focuses on a holistic approach, expanding opioid abuse and prevention and education efforts. The chairman is right. We've got to get into the schools. We've got to get the prevention focused on opioids, prescription drugs, and also heroin. Expands the availability of Narcan to first responders and law enforcement, supports additional resources to identify and treat incarcerated individuals so that we can end the revolving door that we see in our prisons, expands drug take-back efforts to promote the safe disposal of unused or unwanted prescriptions, strengthens prescription monitoring drug programs, and launches prescription opioid and heroin treatment intervention programs. We can administer Narcan, and our first responders are doing an amazing job of bringing people back to life. But if we don't get the support and treatment for those who are struggling with addiction and deal with the underlying issues, we are not going to solve this problem. And as the chairman, and you will hear from Chief Willard today, we cannot arrest our way out of this problem. This is not just about statistics. This is about real people dying. Real people like Courtney Griffin from New Hampshire, who was 20 years old, had such a promising life before her. Real people like the grandmother who told me the other day as she waited on me in the store, I lost my granddaughter. We can make a difference in the Senate and in this committee by passing the Comprehensive Addiction and Recovery Act, by working together to not only support our first responders, but to make sure that we're focusing on prevention, make sure that those who are struggling with addiction, that we get them support for treatment and recovery. Most of all, I want you to know that we can turn this around, because I've also heard the redeeming stories, people like Eric Spofford, who is addicted to heroin and now has established treatment facilities in New Hampshire and is turning this around. But we need to act immediately. This is a crisis. I'm so glad that you're holding this hearing today. I thank all of my colleagues who are working on this issue, and I thank this committee for its leadership, and I look forward to working with you. Thank you.
Thank you, Senator Ayotte. And now Senator Shaheen.
Thank you, Chairman Grassley and Ranking Member Leahy and the members of this committee for giving me the opportunity to testify this morning. I am a co-sponsor of the Comprehensive Addiction and Recovery Act, and I appreciate the leadership of my colleagues, Senator Ayotte and Senators Whitehouse and Klobuchar, and all of you on the committee who are working on that legislation. I'm actually here to testify, however, not on that bill, but on two bills that I've introduced. The Opioid and Heroin Epidemic Emergency Supplemental Appropriations Act. That's a mouthful, but what the bill would do is allocate $600 million in emergency funding to address this national crisis. The second bill is the Combat Heroin Epidemic and Backlog Act, which would authorize a grant program to help reduce the chronic backlog of heroin and fentanyl cases at state police crime labs. And Mr. Chairman, you and Senator Leahy and my colleague Senator Ayotte talked eloquently about the statistics that affect this epidemic. But the fact is, I believe what we have now is a pandemic. It's affecting young and old, it's affecting urban and rural, rich and poor, white and minorities, and it's spreading to every state in this country, including Alaska and Hawaii. In New Hampshire, we're losing more than a person a day to drug overdoses. Last year, 3 times as many people lost to drug overdoses as traffic accidents. And we just had a study come out on mortality rates in this country that showed that mortality rates among middle-aged white Americans are actually increasing for the first time in decades rather than decreasing. And that was attributed primarily to the rising substance abuse disorders. So, as Senator Leahy said, those statistics don't adequately describe the devastation to families who have lost loved ones and who are still struggling with trying to get loved ones into treatment. But despite all these statistics, despite the stories that Senator Ayotte and I have heard in New Hampshire and that all of you have heard in your home states, public health and law enforcement agencies at all levels lack the resources to mount an effective response to the heroin and opioid epidemic. And nationwide in 2013, nearly 9 out of 10 people who needed drug treatment did not receive it. This is tragic and it's unacceptable. And we need to mobilize a national response. You know, my legislation proposes $600 million. Specifically, it provides an additional $200 million under the Edward Byrne Memorial Justice Assistance Grant Fund to fund state and local efforts, including law enforcement, prosecutions, and court programs, drug treatment and enforcement programs, as well as prevention and education. And lest you think $600 million is too much, remember that last year, Congress passed $5.4 billion in emergency funding to combat the Ebola outbreak, and we lost only 1 person in the United States to Ebola. In 2009, Congress passed nearly $2 billion in emergency funding just to fight a swine flu epidemic. So we need better coordination and we need more resources, and I think you'll hear from Chief Willard the challenges they're having in New Hampshire because they don't have the resources they need. I also want to touch briefly on the Combat Heroin Epidemic and Backlog Act, which is designed to help drug labs across this country, crime labs across this country, as they analyze drugs. This bill is modeled on what we did in 2005 to combat methamphetamines. And what we're seeing in New Hampshire and across this country is that state police forensic laboratories have accumulated backlogs of heroin and fentanyl cases because they don't have the resources to do the testing. In New Hampshire, the state forensic lab receives about 750 testing requests each month, but it can only process 450. And the growing backlogs result from an increase in heroin cases and a dramatic surge in fentanyl cases. And just to give you some idea of, Senator Ayotte touched on this, but in New Hampshire, according to our chief medical examiner, in 2013, we had 193 overdose deaths. 18 of those were fentanyl related. In 2014, we had 326 overdose deaths. 145 of those were fentanyl related. And in 2015, we had 385 deaths from overdoses. 253 were fentanyl related. We have got to act with a sense of urgency because delays in processing drug samples have disrupted every stage of the policing and judicial processes. We are no longer able to identify combination and designer drugs by sight. Undercover law enforcement are forced to wait to verify samples before continuing investigations, and prosecutors and judges are less likely to offer plea deals without lab confirmation of a drug's authenticity. So put simply, these backlogs are keeping us from putting dangerous criminals and drug traffickers back in jail and getting them off the streets. So, Mr. Chairman, there's obviously a lot of work that we need to do to address this pandemic. I believe it's something that working together we can overcome, but it's going to take a multifaceted approach, as you've said, and we've got to act now before things get even worse. Thank you very much.
Thank you, Senator Shaheen. Now, Senator Portman.
Thank you, Chairman Grassley and Ranking Member Leahy and members of the committee for having the hearing today and letting us come before you to talk about a critical issue we face in every single one of our states and in practically every community in this country, and that's this epidemic of heroin and opiate abuse. Senator Ayotte talked about S524, which is the Comprehensive Addiction and Recovery Act, CARA. It's a bipartisan bill that addresses this issue head-on, and it does so in a comprehensive way, through prevention, through treatment, through recovery. It's one that I've had the privilege to work on with my colleague and co-author Sheldon Whitehouse, who's on this committee, along with Senators Ayotte and Klobuchar. We've been working on this for a few years now. We've brought in experts from all around the country to give us their best advice. This committee's done some good work already. I was very encouraged, Mr. Chairman, by your comments earlier and by the ranking member's comments about the importance of addressing this issue in a comprehensive way and about the importance of moving this legislation forward. And again, I thank you for that. I think it's the appropriate federal response to this growing epidemic. I also want to thank those experts out in the field from every area, prevention all the way through recovery, who have worked with us over the past few years in putting this together and participated in about a half dozen forums we've had here in Washington, D.C., where they've come in and given us their input. We've all been back home, too, getting input. And no matter where I go in my home state of Ohio, I hear the same story. I hear it from mothers, I hear it from fathers, sisters, brothers, friends. I hear heartbreaking stories of how addiction is ruining lives, tearing apart families, devastating communities. This epidemic is striking very close to home. And I know you're hearing that too as you go home. Last year, 2,482 Ohioans died from a drug overdose. That should demonstrate to all of us how difficult it is to break through this addiction. The bonds of addiction are so strong. Recently, I was in a hospital last week in Cleveland, Ohio, looking at the amazing care they're giving to addicted babies. I had a chance to talk to some mothers who continued to use during their pregnancy. That's how strong these bonds of addiction are. Thousands more, of course, are surviving these overdoses, but they're still struggling. They're struggling to hold a job. They're struggling to take care of their families. Economists tell us that addiction now costs this country $700 billion every year. That's lost productivity, It's more expensive health care. It's what's happening in our emergency rooms in all of our states. It's more crimes. It's the cost of incarceration. It's the cost of policing. That's a lot of money. But of course, it doesn't tell the true cost in human lives. And you all talked about that this morning. It's the cost in dreams that are never fulfilled. I think this hearing will be very effective in helping bring awareness to the severity of the problem. And we've heard it already this morning. But I think it's just as important that we talk this morning about the reasons for hope, that there are alternatives out there. There are ways to address this. There are ways we can make progress in combating this epidemic, and lives can be saved. No one knows this better than Senator Grassley and Senator Leahy, because they've been at this for a couple decades, as was mentioned. I worked with them back on prevention strategies that actually work. And we have spawned more than 2,000 community coalitions together with the Drug-Free Communities Act. But now we need to do more. We need to focus more not just on the prevention and education, but on dealing with treatment and recovery. I've seen some amazing people who lead programs in my state that actually work. I've visited with a lot of men and women who struggle with addiction and have the courage to seek treatment and get on the road to recovery. I've also been fortunate enough to get to know a lot of Ohioans who have taken their personal tragedy and they have channeled their grief into something constructive. They've used their story to help others avoid addiction or help others break the stigma of addiction. You're going to hear from one of those women here this morning. Tonda DeRay, I first met last fall. She came here for the rally on the mall against addiction, and she told her story to me. And her story is one that breaks your heart. Her daughter, Holly, was 21 years old when she died of a heroin overdose. Now, to the outside world, Holly didn't fit the stereotype of someone who was a heroin addict. She excelled in school. She had a lot of friends. She was selected for homecoming and prom court. She was building a life for herself. She was engaged to be married. And then on her 20th birthday, at a celebration, some friends of hers said, "Why don't you try this?" And they gave her some heroin. She thought she would experiment with it. And she got into the grips of addiction. Tonda did, as you'll hear later, I suppose, what any mom would do. She helped her daughter try to get into treatment. Holly went to rehab. She actually gained a period of sobriety. But then the addiction took over. She overdosed. And she died. Tonda, again, has taken that tragedy and used it in a constructive way to help others. Her group is called Holly's Song of Hope. She now has 40 chapters, she tells me, around Ohio and around the country. And it's in the hopes that other daughters will not follow that similar dangerous path. I commend her. There are so many others who've done the same thing I've met in the state of Ohio. Last week, I visited Marion, Ohio, and I met Bethany, who has struggled with heroin addiction. She struggled as a teenager. She was a promising athlete. She was going to college. She had a scholarship, but she got sidetracked through her addiction. She was an expecting mom, and she used. And she says that tearfully now. She was arrested. Law enforcement tried to deal with her issue by not putting her in jail, but finding alternatives. She finally figured out she had to beat her opiate addiction because of her kids. And she did it. Detox was hard, recovery even harder, but she went on to graduate from Marion County's Family Dependency Treatment Court, an alternative sentencing program, where they provide resources for mothers facing substance abuse. After 5 years of being sober, Bethany now leads that specialized docket as the court coordinator to help other mothers in recovery. To my colleagues this morning, the story of Bethany tells us why there is hope in the face of this addiction. You've seen it in your states. We've seen it around the country. People can break this grip of addiction and get into treatment and recovery. It's hard. They need our help. Listening and learning from these families is what helped us inform our work on CARA every step of the way, as Sheldon Whitehouse will tell you. From prevention efforts to law enforcement strategies to addressing overdoses and expanding evidence-based treatment to supporting those in recovery, this legislation is comprehensive. It'll help communities pursue all of these proven strategies, and we need them all. not just one. I'm committed to passing this bill and getting it signed into law because I truly believe it can make a difference in the lives of the people I represent and in the families you represent. I once again want to thank the 9 members of this committee who have co-sponsored this legislation. I want to thank those who are willing to work on getting this reported out and onto the floor for a vote. And again, I'm encouraged to what I've heard this morning. I think HERA is an investment. It is an investment. It's not inexpensive, but it's an investment at a time when communities are desperate for resources and expertise, the best practices that comes through this legislation. It's a small investment for the future. We will know success by empty jail cells, by the number of people who never have to struggle with addiction in the first place, by the moms and dads who now can be reunited with their kids. The message is very simple today. There is something we can do to help. To those who struggle and who think they can't ever overcome, to those who believe there is no one out there to help them, you're not alone. We are with you. There is hope. And that hope can be furthered by this committee leading the way by reporting out this legislation. Thank you, Mr. Chairman.
Thank you, Senator Portman. Now, Governor Shumlin. Go ahead.
Thank you, Mr. Chair. It's a real honor to be here to share some of Vermont's story with you. I got to thank my great friend, Senator Leahy, for inviting me down and giving me this privilege. I'm glad to have my state's attorney here, my U.S. attorney here with me, Eric Miller. And maybe before I add to your colleagues' extraordinary comments on this crisis, I just have to tell you this. You know, when governors give their State of the States or inaugural addresses, it's kind of a big deal for us. We spend a lot of time on it. And we lay out proposals that we think really make a difference. I made the mistake this year of doing that, and halfway through the speech, acknowledging 2 of my favorite people on this earth, Senator Leahy and his wonderful wife, Marcel. They got the longest, biggest standing ovation of the speech, and needless to say, the press wrote, Senator Leahy and Marcel get biggest ovation of speech, and that's all that Vermonters heard about my State of the State. So I won't make that mistake again. Listen, I was going to share with you many of the stories, the heartbreaking stories that you've just heard from your extraordinary colleagues from New Hampshire and Ohio. So I won't. Vermont has the same heartbreaking stories. When I dedicated my State of the State address to this subject, needless to say, it was a pretty lonely place for Vermont to be. There was a long debate about whether Vermont really had that big a problem, and should the governor really be spending this much time on this one. So I got to tell you, it gives me a lot of hope to hear from your colleagues, as well as to see this committee focusing so intently on this challenge that we're all facing together. I came into this knowing very little about addiction, but I was just listening to Vermonters, much like Senator Leahy has as he's traveled around the state, and the heartbreaking stories. And I started asking, so how did we get into this mess, and what do we do to get out of it? And when I started talking to the addicts, to law enforcement, to docs, to nurses, to prevention folks, I learned that we were doing almost everything wrong. Almost everything wrong. Why? First, our criminal justice system was designed to maximize addicts going to prison and not going to treatment. Just plain and simple. I learned that the most likely chance you have to move someone from denial, and denial with this addiction is extraordinary. It makes denial for alcoholism or the other addictions that we all face with our family and friends look small. But the most likely chance you're going to get an opiate addict to agree that they've got a problem and go to treatment is that moment when the blue lights are flashing, the handcuffs are on, and they've bottomed out. And what I found was that in Vermont, we were missing that opportunity every single time. It took 4 or 5 months between getting charged and going before the judge to wind your way through a court system. By then, they were back using, they were back abusing, they were back addicted, they were back in the streets doing crime to feed their habit. So we changed that. We moved to what we call a rapid intervention system, where I literally fund for every state's attorney in our state, but the state funds a assessor, third-party assessor, who every time there's a bust goes in and makes a determination. Is this person someone we should be scared of, in which case they go through the old system and end up most likely in jail? Or is this someone that we should have hope for, get into treatment, and move back to a productive life? And all I can tell you is it's working. We're finding the vast majority of folks who are suffering from this disease won't hurt you, they'll just hurt themselves. And we're moving them to treatment, to recovery, to a comprehensive hub and spoke system. Not that there aren't failures, and not that they don't have setbacks, but that actually moves them into recovery. It has reduced our incarceration population dramatically. Vermont saved $50 million in the last several years, not locking folks up, but instead getting them into the treatment programs and back into a productive life. And it is working as well as one might hope. Second, we've expanded treatment like mad. And even with tough budget times, we've made tough choices, but we're building out our treatment centers as fast as we can. That, too, is having a huge effect. Our problem is that as we have removed the stigma, as you are helping to do right here in this hearing today, Mr. Chair, we have more and more folks who are willing to come forward and say, I've got the disease, I need help. And as we build out the treatment centers, and I know Hampshire is finding the same challenge, we literally are finding longer and longer waiting lines because there's more and more demand. But we've got to keep building out treatment centers. We need help in building out those treatment centers. Third, the rescue kits that your colleagues mentioned about the Narcan is absolutely critical. We were the first state to get into state police hands, into law enforcement at every level, municipal and county, to get it into the hands of firefighters. Everyone will take it. We've saved hundreds and hundreds of lives. This is expensive stuff. We need help saving lives. The prescription drug monitoring program that Senator Shaheen has mentioned she wants to build upon is critical, and we've had governors from all over New England working together to improve the data where folks are shopping for prescription drugs across state lines. So, without telling you more about what I think we're doing right and what's giving me hope, I want to mention a little bit about what isn't giving me so much hope. Listen, we need financial help. The states cannot do this alone. As an example, when Senator Leahy helped to get us a SAMHSA grant for $3 million, it seems like a small amount of money in Washington, but it was huge for Vermont in allowing us to get it to the Howard Center, the Rutland Regional Center, the Chittenden Clinic, to actually help us build out our treatment centers. We're scraping together pennies to try and make our treatment centers stand on their own. So financial help from Washington is critical. I am encouraged by the bipartisan support here in the Senate to help us get the financial resources that every state needs to fight this battle and to win it. So money, huge. Second, we've got to look at what's holding us back in treatment. And one of the things I got to tell you that I found in Vermont is that as we build out treatment centers, particularly this is true of small rural states, where we're having challenges getting enough primary care docs in the medical field to deal with the illnesses that we're all facing, with a Medicaid and Medicare underpayment to them and so forth, we do not have an extra physician force to deal with the magnitude of treatment that is necessary to successfully win this crisis, to get treatment to folks that need it. So you've got to ask this question, and this is a federal change that I beg you to make. Why is it that physician assistants and nurse practitioners can prescribe OxyContin and other drugs that lead to heroin addiction, but they can't prescribe the treatment drugs that would allow someone to get off this stuff and back to normal life? Why is that? So I ask you to help us in expanding the force on the ground that will help us actually be able to treat folks by making it immediately possible for physician assistants and nurse practitioners under the direction of physicians to be able to prescribe the maintenance drugs that allow us to move from addiction. And I just want to close by saying this. We do need to ask this question. Why are we in this mess? What led us into this mess? Why are all 50 states on a bipartisan basis saying we need help? This is everybody that's having this problem. This disease knows no racial boundaries. It knows no income boundaries. It knows no partisan boundaries. Everybody's in. And I think we have to have a more honest discussion about what led us into this mess. Listen, I know that our instinct is to say, wow, those folks down in South America and other places are sending us lots of heroin and it's a huge problem. Well, of course it is. But I ask you, is that a new problem? Has something changed dramatically in the last decade or so that has brought this heroin to America? And I would say no. We've always had this problem of drug dealers trying to support their countries and their wars and everything else by sending illegal drugs to America. So then what did change? And I think it's important for us to have an honest conversation about this. What changed was that we changed our attitudes in America and our practices in America in the late 1990s about how we deal with pain. Why aren't we talking about that? Listen, this I can tell you. I have a lot of hope for where we're headed. I'm incredibly discouraged that we still have more people signing up for opiate addiction in Vermont than we had when we launched this battle 2 years ago. Well, why? Listen, the facts matter. When the FDA approved OxyContin, Purdue, several years later, the manufacturer of that drug, pleaded guilty to telling physicians and docs that this painkiller wasn't addictive. They paid a $60 or $70 million fine in the same year that $11 billion worth of OxyContin and other painkillers were sold in America. Listen, these facts matter. In 2010, we prescribed enough OxyContin in this country to keep every adult in America high for a month. We did. Those are just facts. In 2012, we prescribed 250 million prescriptions of OxyContin. Now, there's only, last time I checked, roughly 250 million people in our country, so that's a prescription for every living American. Just a few years ago, the FDA approved Zohydro. I call Zohydro OxyContin on steroids. We're about to do this all over again, team, and guess what? When they approved Zohydro, they didn't make it tamper-resistant, so you can snort it and you can shoot it. That's what led us into this mess. Listen, just this year, they approved OxyContin for kids. I mean, you cannot make this stuff up. So I ask us to pause, to take a deep breath, and to ask this question. Are we willing to have an honest conversation about the way we're dealing with pain medication in America? Because I can tell you that until we do, all of the good work that we're trying to do together will lead to more tragedy, more loss of life, more of our sons and daughters dying of opiate addiction, because that is what has changed. What has changed is that we simply pass out painkillers like candy in America, and we're unwilling to have that conversation. Thank you.
Senator Leahy.
Mr. Chairman, I assume our Senate colleagues probably have to leave. I've seen the Senate schedule. It's not the House schedule. The Senate schedule is pretty busy, and I'd ask that the senators be excused, but I do have a question for the governor.
Yeah, if you want to go. I don't have questions for you. We can talk anytime, but, and I look forward to continued conversation on this legislation with my colleagues. So you can stay if you want to. Go ahead, ask Governor Shumlin your question.
Well, thank you, Mr. Chairman. Governor, you and I have talked about this a lot, and I appreciate your passion. I would note for everybody here, this is not just something the governor says publicly. He's talked about a lot privately. And I think it's fair to say you feel as the same way that I've heard from police officers all over the state of Vermont. It's not just a law enforcement problem. It's I think a lot of them certainly tell me, both that the federal level of police, the state police, local police, county, they tell me if they could get people into treatment, they much prefer doing that. Is that the same thing you're hearing?
Absolutely, and I've got to say that law enforcement has been an extraordinary ally in this battle. And I know this is true not only in Vermont, but across the country. I was recently on a panel with the police chief in Gloucester, Massachusetts, who literally said, listen, here's my policy. And now New Hampshire and Vermont law enforcement folks are doing exactly the same thing. If you're addicted to opiates, come to my station. We won't arrest you. We'll get you into treatment. We'll get you into recovery. We're not arresting any more folks who are addicted to this disease and are nonviolent. And, you know, I sometimes think we don't give law enforcement enough credit for being on the front lines of this. For years, we said to law enforcement as a nation, this is your problem, go settle it. And, you know, if I were law enforcement, I'd be a little raw about that. But instead, they've said, hey, we want to partner with the medical community. We want to partner with treatment folks. We want to partner with the judiciary. We want to partner with families to try and solve this problem as a disease, not a crime. And, you know, without them, we would not be where we are.
But we also have to have a place where they can bring these people. If we're going to have a diversion program, I think we'd all agree you got to then have the people.
Absolutely.
People there, right?
Absolutely, and we're literally scraping together the resources to try and pull this off. I cannot tell you that Vermont, probably I bet you anything the senators from New Hampshire and Iowa would say the same thing, that we're not there yet, but we're doing the best we can with the resources we have.
Well, Senator Grassley is mentioning to me nurse practitioners. I yield to you on that.
I think we ought to follow up. We have a lot of, you know, nurses, the attitude towards nurses in America is you can't do you a nurse unless you got a doctor looking over you. We got to change that, and I think your suggestion, but in rural America, we're going to have to make greater use of nurse practitioners.
I'm somewhat partial to nurses, as you know, and I have a daughter-in-law who is a nurse, active nurse practitioner.
I guess in the order of Durbin and then White House, and then Klobuchar.
I want to thank my colleagues for coming. I've done roundtables around Illinois. There is no town too small, no suburb too wealthy not to have heroin overdose deaths in the state of Illinois. I want to especially thank Governor Shumlin because I think you pointed to something that we need to point to. We can all endorse the legislation that's been described, every single piece of it. I looked at it and think, I'm for that. You go to the heart of our responsibility. The Food and Drug Administration, the pharma industry, the dirty docks. You know, we don't have to go to the border here to see the source of opioids. You go to the pain clinic in the mall. You go to the doctor, you know, just around the corner. You go to the pharmacist who looks the other way. And clearly, I think we have a responsibility here. Pharma is making a fortune off this. Now, I'll concede the fact that over the last 10 years, we have decided to tackle pain directly, and I'm glad. For a lot of people, it's the difference in quality of life that we have to readily acknowledge. But with it has come a dramatic abuse. To think that the prescriptions, legally written prescriptions in this country, result in a bottle of pills for every single adult American, as you said, to treat them with this drug for at least a month, tells me it's out of control. Congress, what are you doing about this? Senate, what are you doing about this? And the FDA dreaming up new applications for children and for super opioids? Where in the heck is the Congress in terms of our responsibility when it comes to this? And the second point I'd like to make is that police chief in Gloucester ought to be here today, because Dixon, Illinois, population 20,000, went to visit with him and decided after 4 heroin overdose deaths in one weekend, they were going to buy into his program. 25 kids came forward, young people came forward. You know what happened? They went into treatment.
Yep.
And you know what happened to the jail? It was empty. The petty crimes, the burglaries, the thefts to sustain these habits started disappearing. But there's a key element here. How did they get into treatment? If they're lucky enough to have health insurance in their families, they have access. If they're lucky enough through the Affordable Care Act to have access to Medicaid, then they get into treatment. And we all know we don't have enough resources here to treat these people. We absolutely, positively have to do it. I want to commend, too, we have our senators from Minnesota here. It was Senator Wellstone and Senator Domenici in a bipartisan effort that demanded and finally after years succeeded in bringing reform to health insurance so that it now covers mental health counseling. It now covers addiction services. Those who want to repeal the Affordable Care Act, put your hand up if you want to repeal that part of it. It would be disastrous across America when we consider this drug overdose and other things. Thank you for really turning the spotlight back on us. It's not just all the things we've heard. We've got to look at FDA, pharma. We've got to look at what's going on with the illicit prescription and filling of prescriptions across America. That is our responsibility. Thank you.
I'm going to have to go back and forth, so I'll call on Cornyn and then White House.
I just wanted to take a second to thank our colleagues for your powerful presentation here today. And I think what we're seeing in America is that we're reconsidering a lot of our criminal justice policies. And this committee's, under the leadership of Chairman Grassley, has passed out, for example, a criminal justice reform bill, something I know that Senator Portman and others have worked on a lot. But I hope that as we look at this terrible pandemic, as Senator Shaheen called it, we look at this comprehensively. Because I don't know if you can draw any artificial lines between dealing with mental health issues in the criminal justice system and drug addiction issues, because we know from talking to our sheriffs that many of our jails are populated by people with mental health issues for which they self-medicate if they are unable to find other places where they could get some help. But I would also like to make a plea of my colleagues on behalf of somebody who represents a state with 1,200 miles of common border with Mexico. Its demand is a big problem. Governor, I thank you for your powerful testimony. But we also need to deal with the supply issue as well. And I know it's tough. Our friends in Mexico say, well, we wouldn't have all the drug cartel activity and all the transportation of drugs into the United States if there wasn't such demand in the United States. So we do have to deal with both of those. But I hope as we look at this, we won't draw any artificial lines or create any stovepipes, and we will try to find a way to deal with this in a broader, more deliberate sort of way. Thank you.
Senator Whitehouse.
Mr. Chairman, I'll put my statement in the record so we don't go on too great length. We have two panels ahead of us still. But while Senators Portman and Ayotte are here, I wanted to thank them for the terrific work they did as original co-authors of the CARA bill. Senator Klobuchar and I are very grateful, and they were joined by Senator Kirk and Senator Coons as well very early on in the proceeding. So I thank them, but I also want to particularly thank Senator Hatch and Senator Graham, who were the first two committee sponsors on the majority side for this bill, and they've helped make sure that we have this hearing today. And I want to just make a record of how important Senator Hatch and Senator Graham have been to getting us to this point, in addition, of course, to the chairman himself who made the call. So thank you very much, and whatever else I'll add to the record.
Okay. Senator Tillis, and then Senator Klobuchar.
Thank you, Mr. Chair. I'll be brief. To my colleagues, thank you for being here, and thank you for your work on this. And Senator Ayotte, as I've already expressed to you, special thanks for you wearing Carolina Panthers black and blue today after your Patriots got eliminated. Governor, I've well, I think it's a great step, and look forward to seeing it move through the process. Governor, I had a question for you. I am a personal friend of your speaker. I've known him for about 5 years, having been speaker down in North Carolina. To the point that Senator Cornyn is making, and I do agree to a large extent with what Senator Durbin said, but if we focus on, for example, the prescribed painkiller problem, then I think we're going to see an increased uptick in heroin abuse. I mean, it's obvious it's happened in North Carolina. It's a matter of state policy. We did a number of things to crack down on drug shopping and the sorts of things that we were seeing in the state, and there's almost a direct correlation between a reduction in those prescribed opioids and an increase in heroin abuse. So as a matter of state policy, what are you all looking at now? I'm also very struck by the fact that some states, there are great disparities between overdoses and deaths. I was shocked to know that ours had gone up 480% over 3 years, but it's still a fraction of what a state that's got 1.5 million people have versus a state that has 10 million people. So, what are we doing to address these specific issues, and what risk do we run of federal policy potentially hampering what you think and your speaker and your Senate leader need to do to address the things that are unique to some of these states that seem to have disproportionate problems?
Yeah, that's a great question, Senator, and I can't tell you why some states are being hit harder than others, but this I'm convinced of. I don't think that we would have the heroin problem in America if we weren't starting folks out on opiates that are sold over the counter stores. It isn't coincidence that our irrational exuberance around painkillers is matched by the rising heroin crisis. And so I am convinced that if we went back to the old policies on pain medicine, which is when someone has chronic pain, treat it, and treat it hard. But don't pass this stuff out as if it's not a problem, which is what we're doing. I'll give you an example, and I know we can all tell these stories, but the other day I had a reporter come into my office, and she just had surgery for carpal tunnel, or whatever we all call it. And I said, how many did you get? She said, what do you mean? I said, how many oxys did you get? She said, 80. I said, good. I said, how many do you take? She said, half of one. So there's 79 and a half left behind. 3 weeks later, my head of healthcare his daughter comes by. She's a sophomore in college. She'd had 4 molars pulled out. I said, did they give you any painkillers? She said, yeah. I said, what'd they give you? She said, oxy. I said, how many do you get? She said, 40. I said, how many do you take? She said, none. So there's 40 more. And my point is, there is no question that when we made it tamper resistant, folks went to the pure heroin because it's cheaper, it's easy to get. But we cannot lose sight of the fact that we were not having this problem prior to the invention of OxyContin. We just weren't. And we've got to go back to the source. I think as the senator from Illinois said eloquently, listen, let's remember, I mentioned Zohydro. When the FDA approved Zohydro, its own advisory panel, 13 members, I believe, voted 11-2. FDA, do not approve this drug. They did. So my point is, there is a correlation. If you talk to folks who are addicts, which I've done, and many, many times, 80-90% of the times, folks say to me, I got in a car accident, I had surgery, this happened to me, knee, whatever it was, that led me into this mess.
Senator Shaheen wanted to add something.
I did. I think we've talked about the FDA. Everybody here has talked about pharma and the role of prescription drugs. But what we haven't really talked about is medical schools and doctors. It's my understanding that most medical schools don't have any courses on prescribing medication, on recognizing drug abuse. And it seems to me that we've also got to get some attention from medical schools who are turning out doctors who are doing these prescribing practices without the history of what has been raised here at this hearing.
Amen.
Senator Ayotte.
I certainly fully agree with Senator Shaheen on this. We have to engage the medical community on this, but also, for example, in New Hampshire, back when I was Attorney General, I was fighting for prescription monitoring then, and our state was late to the game on it, because when we look at this data and giving physicians the information that they can have, and that's one of the pieces of this CARA bill, is to support the prescription monitoring programs. Physicians that want to do the right thing, it gives them the data to understand if someone's doctor shopping. It also gives us the focus to know if a particular doctor is actually exceeding his or her bounds, because it's all focusing on them. And so that allows us to address that. But we have to engage the medical community, and I think SAMHSA, who you'll hear from, will tell you that, as I understand it, some of the work they've done nationally, 4 out of 5 people started with overusing or misusing prescription drugs. And to your point, Chairman, that you raised in your opening, we also right now, with the patient survey, are actually encouraging reimbursement based on how satisfied people are with pain, and that has to be addressed as well. And I know that CMS is looking at this, but it has to be a priority because we don't, and this was brought to our attention from doctors who are concerned that if they're worried about an addiction issue, they're being judged on a survey that's saying, how's your pain satisfaction? So that has to be addressed as well.
Senator Portman and then Senator Klobuchar.
Yeah, just quickly, Mr. Chairman, I don't disagree with the comments that were made here, and as a result, in this legislation, we not only have the drug monitoring programs, which are incentivized, and to Senator Tillis's question about how the states will respond to this legislation, it doesn't mandate the states to do this. It does provide incentives, which I think is very important to your point that every state's going to be a little different, and some states have done some really cutting-edge work, and they should be the laboratories of democracy in this, but we're helping them on this prescription monitoring program, including across state lines. Think about it. In our states, we may have a great program. In my state of Ohio, Southern Ohio, West Virginia, and Kentucky have different programs. You don't know if somebody got a prescription filled in Ohio and there without having better interstate, and that's something that the federal government can exclusively do. We have legislation on that. Second, this drug take-back program is incentivized in this legislation. So CARA focuses on getting some of those drugs off the shelves, which Governor Shumlin's absolutely right. The final thing I'll say, though, is that, having talked, to hundreds of people who are recovering, who have been addicts because of prescription drugs, I understand that issue very, very well, including the athlete I talked about earlier. But I will also tell you there are a lot of people I've talked to who jumped that step and went straight to heroin. And Holly's an example of that, as we'll hear about later from her mom, Tonda. And I think now, because heroin is so plentiful, I was just with the FBI in Ohio yesterday talking about this. The drug cartels from Mexico are in Ohio, they're in Illinois, they're in our states. Because it's so plentiful, because it's so cheap, it's not just about prescription drugs anymore. It has been a gateway for a lot of people, but now there is a problem we have directly with heroin, even first use. And back, in the days when we worked on this issue of cocaine and marijuana back in the 90s, heroin was not a first-use drug. It was a drug that you used after you had other gateway drugs, typically. With young people as young as 13, 14, 15 years old, they are using heroin today. So this legislation is comprehensive. It does deal with the prescription side, but it also deals directly with the heroin issue, which sadly we now have to confront, perhaps because of this onslaught that came from the overuse of pain medication, but now the heroin is upon us.
Senator Klobuchar.
Thank you very much, Mr. Chairman. I'm proud to be an original co-sponsor of this bill with Senator Whitehouse and Senator Ayotte and yourself, Senator Portman. I just want to say get to this point about what we should really be looking at here and what we have some control over in the Congress. I'm a former prosecutor. I know that these drugs have been coming in, as you've stated, Senator Portman, but I think the number one thing that we can do right now, in addition to funding our law enforcement, making sure we have efforts with DEA funded, is really go after what's been happening with prescription drugs. Because while it is true that there are people that originally get hooked on heroin, the facts are the facts, as Senator Ayotte just said. 4 out of 5, that's 80%, this is the last statistic I had, 4 out of 5 of these heroin users started with prescription drugs. And what the governor has been telling us, what Senator Durbin has been telling us here, is that this is different than it was even when I started as a prosecutor in 1998. This is a different situation. We have these prescription drugs. I bet everyone in this room either has some in their cabinet, has had some in their cabinet, or knows someone in their family where you just took 1 or 2, as the governor pointed out, and there's 20 left, or there's 30 left, and they are sitting in there. Senator Cornyn and I passed a prescription drug take-back law years ago. We finally got the rules out of DEA so we could get that moving, but that is not going to solve it if it just keeps happening over and over again. In this bill are the work that Senator Ayotte and I did on the prescription drug monitoring, but just having come from a state here where we're not just the land of 10,000 lakes, but 10,000 treatment centers, the home of Hazelton Betty Ford, I know from talking to those doctors and experts that we are not really going to change this until we change the way these painkillers are given out. And that's why the doctor monitoring, the having more limited dispensation of these kinds of drugs is going to make the biggest difference here, because I'm all in on trying to do everything we can to keep these dangerous drugs out of our towns, but the change here and what we have more control over is how we get these people hooked on drugs in the first place. And sometimes they are such innocents. They just have a bad back. And no one warns them that given their particular makeup, if they take these drugs for 4 days instead of maybe just 1 day or maybe just one, they're actually going to get hooked. We are doing this in our country, our policy, not a drug dealer on the corner. So that's what I think we need to focus on, and that's why I'm pleased with this bill.
Senator Sessions.
Well, I think Senator Klobuchar is correct. There was an important point. There's a reporter with the New York Times that's written an online book that says these pills delay healing, the pain pills. The more you take, the longer you have these problems. And he had a lot of points that we really need to reduce the amount of prescription drugs out there. As a former prosecutor myself, we targeted prescription drugs in Mobile, Alabama. It can be the most successful reduction of drugs there is because there are not many sources. Only if certain doctors were way over the list. We found really the illegality was coming from drugstores to drugstores. So when you eliminate that, you don't plea bargain with people until they tell you where they got their pills. You can pretty quickly go right back to the sources that are out there. This is a winnable thing, and it does lead to additional drug use. So thank you, Mr. Chairman.
Senator Coons.
Thank you, Chairman Grassley and Ranking Member Leahy. I just hope the American people notice the striking bipartisanship this panel has shown, senators and governor, the questions, the comments that we've heard from members of the Judiciary Committee, the input we've heard from senators who have worked so hard on this issue for a long time. My home state of Delaware, like your states, is also struggling with an opioid addiction challenge that has translated quickly into a heroin epidemic that has penetrated every level of society and every background. And I, too, have stories I could share about our local law enforcement and paramedic and first responder community. I'm just thrilled to be able to support both CARA, a bipartisan bill, which lays out the sort of authorizing background for expanding prevention and supporting recovery, and Senator Shaheen's emergency supplemental to make sure we've got the legal framework and the financial resources. This is a genuine problem in all of our states. And it's my hope that folks who are watching recognize you've got Republicans and Democrats working together to craft a thoughtful, broad strategy. And it's my real hope we will get these bills moved. Thank you, Mr. Chairman. Thank you, members of the panel.
We've had a forceful discussion. Very seldom do our colleagues get involved with questions from their colleagues. And thank you all very much for your patience. I'm going to move on to the second panel now. And I know that I don't have to tell you that we'll be talking about this in the future because you're going to make sure we do.
Thanks, Charlie.
Okay, the second, while we have commotion, I'm going to call the second panel. Our first witness is Michael Botticelli, Director, National Drug Control Policy at the White House. As director, he heads the Obama administration drug policy efforts and is responsible for creating the annual National Drug Control Strategy. Previously, he served as Director of Substance Abuse Services, Massachusetts. He has an undergraduate degree from Siena College and a Master's of Education, St. Lawrence University. Second witness, Dr. Nora Volkoff, Director of the National Institute of Drug Abuse, which supports most of the world's research on health aspects of drug abuse addiction. Previously, she worked at the Department of Energy's Brookhaven National Laboratory, where she held several leadership positions. She earned her medical degree at the National University of Mexico. Our third witness, Akena Enomoto, she serves as the Acting Administrator, Substance Abuse Mental Health Services Administration. That agency leads public health efforts to advance the behavioral health in our country. She has worked at SAMHSA since 1998, earned a bachelor's degree and a master's degree in psychology from UCLA, and is also a graduate of Harvard Kennedy School Government. Our final witness is Louis Malahone, Deputy Assistant Administrator, Office of Division Control within the Drug Enforcement Administration. In that position, he is responsible for overseeing and coordinating major pharmaceutical and chemical division investigations, drafting and promulgating regulations. He has been with the DEA in multiple capacities since 1997 and holds a BA from Villanova University and JD Rutgers. We will go with the way that we introduce you, so would you please start out, and you appear before our committee many times. Thank you for returning.
Great. Thank you, Chairman Grassley. Members of the committee, thank you for the opportunity to be here today to discuss the issues surrounding opioid drugs, including heroin and fentanyl in the United States and our response. As you know, this is an important issue for President Obama. During his State of the Union address earlier this month, the President specifically mentioned addressing prescription drug use and heroin as a priority, and an opportunity to work with Congress on an issue that transcends party, income level, gender, and race. I also want to thank many of the members who are here today for their ongoing leadership and support for the work of our office on this most pressing public health and public safety issue. The Office of National Drug Control Policy produces the National Drug Control Strategy, which is our blueprint for drug policy. Using our role as coordinator of federal drug control agencies, in 2011, the administration released a plan to address the sharp rise in prescription opioid drug use. This plan contains action items categorized in 4 areas, many of them already discussed today: education of prescribers and patients, increase in use of prescription drug monitoring programs, proper medication disposal, and law enforcement efforts. Since this plan was released, this crisis has clearly evolved, with an increase in heroin use and fentanyl use and overdose deaths, and the administration has put forward new initiatives to help deal with emerging issues. As all of you know, and have all indicated, we need a comprehensive and multifaceted response and coordination at the federal, state, and local levels. Opioids are taking a horrific toll on public health and safety in countries across the United States. We all talked about the staggering numbers, so I won't repeat them here. These numbers are harrowing, however, but we are making some progress in addressing prescription drug misuse. Past month, non-medical use of opioids by Americans 12 and older was significantly lower in 2014 during its peak in 2009. The number of people initiating non-medical use of prescription pain relievers in the past year also decreased significantly. This progress, however, has been counteracted by an increase in the availability and use of heroin, although non-medical prescription opioid use continues to far surpass heroin use. Heroin purity has been rising while prices have remained low. And this heroin crisis has been compounded by the reemergence of illicit fentanyl, a powerful synthetic opioid that is sometimes added to heroin to increase its potency or used on its own. Since fentanyl is far more potent than heroin, it has increased risk and increased overdose death in the United States. Although the transition from non-medical prescription opioid use to heroin occurs at a very low rate, a recent article concluded that this transition appears to be part of the progression of the disorder among those with frequent non-medical prescription opioid use or dependence. We've all talked about the need for enhanced prescriber education and graduate medical education programs because they do not provide a comprehensive focus on identification and treatment of opioid use or safe and effective opioid prescribing. In one of the most jarring studies that I have seen in my 10 years in doing this work, a recent evaluation of healthcare claims data found that a majority of non-fatal opioid overdose victims were receiving an opioid for a prescriber at the time of their overdose, and most alarming, 91% of them received an opioid prescription again from a prescriber, 70% of them from their own prescriber before an overdose. In response, last year, President Obama issued a presidential memorandum requiring all federal agencies, to the extent permitted by law, to provide training on the appropriate and effective prescription of opioid medications for their staff who prescribe controlled substances. The administration also continues to press and would continue to work with Congress to pass mandatory prescriber education tied to controlled substance licensure. The administration has focused on several key areas to reduce and prevent opioid overdoses from prescription opioids and heroin, including educating the public on overdose risks and interventions, increasing third-party and first responder access to the opioid reversal medication naloxone, working with states to promote Good Samaritan laws, and connecting overdose victims and persons with an opioid disorder treatment. We appreciate that Congress provided more than $400 million in funding in the FY16 Appropriation Act specifically to address the opioid epidemic, an increase of more than $100 million from 2015. To address the emerging rise in heroin and fentanyl use, our 2015 strategy focuses on identifying, disrupting, and dismantling criminal organizations who traffic in opioid drugs, working with the international community to reduce the cultivation of poppy, identifying labs creating dangerous synthetic opioids like fentanyl, and we have also been enhancing our efforts along the nation's borders and have been actively engaged with the government of Mexico on supply reduction issues to decrease the flow of these drugs in our country. Finally, this past summer, ONDCP committed $2.5 million to our high-intensity drug trafficking area program to develop a strategy to respond to the heroin epidemic, providing resources, enforcement resources to address heroin threats across 15 states and the District of Columbia. This administration continues to work with our federal, state, and local tribal partners and reduce the public health burden and consequences of prescription opioid, heroin, and fentanyl. And I want to thank you for your ongoing commitment to address this public health, public safety concern. Thank you.
Thank you, Dr. Bacciali. Now, Dr. Volkov. Push the red button.
Yes, good morning, everyone, and I want to thank you all for giving me the opportunity to participate in this hearing. What is at the nature of the problem? Chronic pain is among the most prevalent and debilitating medical conditions, with over 30% of Americans suffering from some form of chronic pain. The effectiveness of opioid analgesics for severe acute pain and the limited therapeutic alternatives for chronic pain have combined to produce an over-reliance on opioid pain medications, even when the benefits for chronic pain are questionable. What is no longer questionable is that opioid medications are being widely diverted and have produced an epidemic of opioid overdose deaths and addictions, including those from heroin. Opioid medications, such as oxycodone and hydrocodone, are diverted and abused because, just like heroin, they bind to opioid receptors. Opioid receptors are located in regions of the brain that regulate pain, which is why they are such potent analgesics, but they are concentrated also in brain-reward regions, which is also why they produce addiction. Opioid receptors are also located in brain regions that control breathing, which is also why they can produce overdose and death. So how can NIDA and has NIDA help in the issue? NIDA supported the development of the 3 medications that are currently approved for the treatment of opioid addiction: methadone, buprenorphine, and naltrexone. There is strong evidence for the effectiveness of these medications in the treatment of opioid use disorders, in the prevention of overdoses, in the prevention of infections such as HIV and hepatitis C, and in improving the obstetric and neonatal outcomes of opioid-addicted pregnant women. Despite this strong evidence, less than 40% of those being treated for opioid addiction receive these medications. Thus, expanding the access to medications for addiction is a critical part of the HHS strategy. Towards this end, NIDA funds research to develop implementation strategies for the use of medications in substance abuse treatment programs, in the healthcare system, and in criminal justice settings. Examples in healthcare include initiating buprenorphine in the emergency room, or integrating the management of these medications within infectious disease clinics. Examples in the criminal justice setting include initiating methadone or buprenorphine the month prior to release, or the use of Vivitrol, a once-a-month injection that blocks the action of heroin or other opioid drugs, thus interfering with relapse and death from overdose during this high-risk period. NIDA also funds research to develop treatments that will improve compliance, such as formulations that require dosing every 6 months, or new transformative solutions, such as the development of a heroin vaccine. A second key component of HHS strategy against this prescription epidemic is expanding the use of naloxone, Narcan, a medication that can rapidly reverse an opioid overdose. To this end, NIDA has funded the development of naloxone preparations that do not require injection, thus making them much easier to use for those that have no medical training. One of these products, nasal Narcan, was just approved by the FDA last year. Finally, since the limited treatment alternatives for the management of severe chronic pain has led to the over-reliance on opioid medication, NIDA also funds development of better and safer treatments for chronic pain, including novel formulations that are less addictive, pain medications that are not relying on the opioid system, and non-medication interventions. The epidemic of opioid prescription abuse and the rise in heroin use resulted both from a lack of knowledge of healthcare providers on the management of pain, including appropriate use of opioid medication, as well as the lack of knowledge around identification and management of addiction. Thus, a fundamental component to reverse this epidemic requires the education of healthcare providers, both in management of pain and in substance use disorders. To help address this, NIDA, in partnership with other NIH institutes, has created centers of excellence for the development of education curriculum for pain and substance use disorders. The urgency to address this epidemic is highlighted by the nearly 30,000 deaths from opioid overdose that occurred in 2014, the highest ever reported. Solutions are already available. The challenge is their implementation. NIDA will continue to work closely with other federal agencies, community organizations, and private industries to address these complex challenges.
Thank you, Dr. Volkov. Now, Ms. Enomoto.
Chairman Grassley, members of the committee, thank you for inviting me to represent the Substance Abuse and Mental Health Services Administration today. It's a great honor to talk with you about the role SAMHSA plays in advancing the nation's behavioral health and what we're doing to address the opioid crisis. I also want to thank the first panel, Senators Ayotte, Portman, and Shaheen, Governor Shumlin, who are providing great leadership to raise awareness and catalyze action. I know that this crisis has had devastating consequences in all of your states, but I agree with you, Mr. Sessions, this is a winnable battle. You've already heard that we are facing a treatment gap of unacceptable proportions. As a nation, we will not stem the rising tide of this public health crisis if only 2 out of 10 people with an opioid use disorder get the treatment they need. It wouldn't work for diabetes, it wouldn't work for HIV, and it will not work for addiction. But like many other issues we face, closing the treatment gap will be a complex effort requiring a multifaceted approach. The federal government needs to work with preventionists, healthcare providers, payers, treatment systems, public health officials, states, tribes, law enforcement, community organizations, and the recovery community in order to tackle the challenges ahead. As you have heard, addressing substance use disorders related to prescription opioids, heroin, and fentanyl are key priorities for this administration, and SAMHSA is proud to support the President's National Drug Control Strategy and Secretary Burwell's opioid initiative. The goal of the HHS initiative is to reduce opioid abuse dependence and overdose-related deaths, and it has 3 main aims. 1, changing prescribing behavior. 2, increasing access to naloxone. And 3, expanding the use of medication-assisted treatment and recovery. Today, I'll focus specifically on SAMHSA's role in each of these goal areas. With respect to prescribing behavior, it's an obvious tactic to prevent prescription opioid misuse by reducing the number of pills in people's medicine cabinets. To do that, as we've noted, physicians and other providers need to be better educated on proper prescribing and dispensing of opioids, complemented by training on evidence-based strategies to manage chronic pain, as well as to prevent and treat addiction. We understand that the vast majority of physicians and other prescribers are not bad actors. In fact, most are dedicated, well-trained professionals who are committed to their patients' good health, but they are very busy, and it's hard to find time for elective training that's not required. Since 2007, SAMHSA's provider clinical support system for opioid therapies has provided continuing education to over 72,000 primary care physicians, dentists, and other healthcare professionals. That is tremendous progress, but we have a long way to go. SAMHSA has also addressed the issue of prescribing practices through grants to increase PDMP interoperability and intraoperability And in FY 2016, with Congress's support of a new grant program, SAMHSA will support states, tribes, and territories to utilize PDMPs and other data to identify communities with the greatest need for prescription drug prevention programming. SAMHSA also reaches local communities to prevent substance misuse and abuse through the Drug-Free Communities grants we administer with ONDCP. These coalitions do yeoman's work to create community environments that promote health and prevent drug use, including the misuse of prescription drugs, heroin, and fentanyl. The second aim of the Secretary's initiative is increasing access to naloxone. As you know, and as you've heard today, naloxone can reverse a potentially fatal opioid overdose, but it only works if you've got it when you need it. SAMHSA offers an overdose prevention course for prescribers and pharmacists. One targeted strategy to ensure naloxone is nearby when needed is to co-prescribe the product with opioid analgesics, particularly for patients at high risk of overdose. Another important SAMHSA resource is our opioid overdose toolkit. It is, in fact, the most downloaded publication on our website. And in the coming months, SAMHSA will issue a funding announcement for grants to states for the purchase and dissemination of naloxone and for training to first responders in communities of high need. Imagine how many lives we will save. The third aim of the Secretary's opioid initiative is expanding the use of medication-assisted treatment. There are many pathways to recovery, and it is critical to ensure each individual has access to the full continuum of evidence-based services. Research tells us that medications, along with behavioral health treatment and supports, are important components of an evidence-based treatment plan. However, MAT remains significantly underutilized. Today, there are only a few FDA-approved medications to treat addiction, and patient access to them may be limited. That's why we are so grateful that in FY 2015 and 2016, Congress provided new funding for states to expand treatment capacity, both through increases to the Substance Abuse Prevention and Treatment Block Grant and discretionary funding specifically for MAT. SAMHSA has also worked with ONDCP and DOJ to clarify and enhance the connection between MAT and the criminal justice system through our drug court grant program. Drug courts are the most successful criminal justice response to addiction in our nation's history, transforming lives, supporting lifelong recovery, reuniting families, reducing crime, saving tax dollars, and now serving as the foundation of criminal justice reform in the states. This year, we will prioritize treatment that is less susceptible to abuse and expand our technical assistance to ensure that evidence-based practices are fully implemented. As the Secretary announced in September of last year, HHS has initiated the rulemaking process to increase the cap on the number of patients to whom physicians may prescribe buprenorphine. Because we're in the middle of rulemaking, I'll look forward to coming to talk to you more about that in the future. Finally, it wouldn't be a hearing about behavioral health if we didn't talk about the workforce. Together, the ACA and MAPIA are expected to expand parity protections and coverage of behavioral health services to 60 million people. We must act swiftly to ensure that the behavioral health workforce is sufficient to meet the growing demand. The expanded workforce includes prescribing and non-prescribing professionals, psychiatrists, psychologists, social workers, nurses, counselors, therapists, and peers, both youth and adult. We are grateful for the administration's and Congress's support of SAMHSA and HRSA in this crucial area. Members of the committee, thank you for convening this important hearing. You know all too well that substance use disorders come at great cost to society. The impact of untreated or undertreated behavioral health conditions on the labor market, the criminal justice system, schools, and communities is tremendous, but above all, the impact is greatest on individuals and families. SAMHSA's budget accounts for just over 10% of what the nation spends on substance abuse treatment annually. We are small but mighty. We are steadfastly committed to using our investments strategically, responsibly, and effectively to deliver the greatest possible impact for the American people. Thank you very much.
Now, Mr. Melignoni.
Thank you, Chairman Grassley, Ranking Member Leahy, Senators. It's an honor to appear before you today. DEA views the combined prescription opioid and heroin abuse epidemic as the #1 drug threat facing our country. I appreciate the opportunity to appear before you today and talk about what we at the DEA are doing to address this threat. DEA understands that we need a balanced, holistic approach to this epidemic. Our efforts are designed to ensure patient access to the medications while at the same time preventing the diversion of these highly addictive, dangerous drugs. We stand with our interagency partners, including those represented here today, and embrace comprehensive prevention, treatment, and education efforts as critical to our success. However, enforcement has to be a key component of that strategy. We need to investigate and bring to justice not those suffering from opioid use disorder, but those that are exploiting human frailty for profit. Our answer to this drug threat: attack supply, reduce demand, empower communities. DEA's 360 strategy. There are 3 prongs to it: law enforcement, diversion control, community outreach. My initial comments today focus primarily on the Office of Diversion Control's role in that strategy, but we'd be more than happy to follow up with details about Operation Rolling Thunder. Rolling Thunder is the heroin enforcement prong of this strategy that focuses on the toxic business relationship between the Mexican cartels that are flooding our country with heroin and the violent distribution cells that are slinging that dope in our communities. With 1.6 million DEA registrants, DEA Diversion is uniquely positioned to assist in this fight with enforcement, education, and engagement. The vast majority of those 1.6 million registrants are law-abiding citizens. These are our practitioners, pharmacists, manufacturers, distributors spread across this country. We investigate the very small percentage that are operating outside the law that yet inflict considerable harm on our country. For example, practitioners not prescribing for a legitimate medical purpose outside the usual course of professional practice. Pharmacists not performing their corresponding responsibility to ensure that a prescription is valid. Manufacturers and distributors not upholding the regulatory obligation to prevent diversion. How do we do it? With our tactical diversion squads and our diversion groups. Our tactical diversion squads are specialized units made up of agents, diversion investigators, and intel analysts. We have 69 of them deployed nationally. We're in the process of creating 2 mobile tactical diversion squads that give us the ability to deploy where the need is, giving us a fluid enforcement capability. We have more than 600 skilled diversion investigators spread across this country in our diversion groups. Both the tactical diversion squads and the diversion groups work with their respective U.S. attorneys' offices to bring criminal and/or civil charges, and where appropriate, administrative actions. Our orders to show causes are immediate suspension orders, potentially revoking a DEA registrant's registration. As I said earlier, enforcement will be a key part of this strategy, but engaging with that large registrant community and educating them are just as critical. In the last 2 years, DEA Diversion has conducted more than 300 events, providing education and guidance to thousands of DEA registrants and others. In the coming weeks, I will be meeting with a number of industry leaders to discuss areas of mutual concern. Increased dialogue and appropriate collaboration with industry are crucial to our collective efforts. Finally, we will continue engaging with our interagency partners on these important initiatives that were discussed earlier today: expanding access to treatment, mandatory prescriber education, and the safe and responsible disposal of unwanted, unused prescription drugs. We look forward to the day when drop boxes are so commonplace throughout our communities, in chain pharmacies and elsewhere, that people can dispose of their unwanted drugs conveniently, frequently, and safely, ensuring that those pills don't get in the wrong hands and start someone down the journey toward opioid use disorder. Until that time, the DEA will continue our national take-back initiative with national events approximately every 6 months. During our September 26, 2015 take-back, we collected 741 tons of unwanted, unused drugs from 5,202 collection sites. Our next one is scheduled for April 30th, 2016. The DEA stands with our interagency partners and embraces a balanced approach that attacks the supply, reduces demand, and empowers communities. For almost 20 years, I've had the privilege of working with the brave men and women of the DEA, along with our federal, state, local, and foreign counterparts, investigating some of the most entrenched domestic and foreign criminal organizations threatening our country. This current prescription opioid and heroin abuse epidemic is unlike anything I've ever seen. I know statistics have been mentioned, but in the last 4 years, more than 100,000 Americans have overdosed and died. This is an unimaginable tragedy. We at the DEA will do whatever it takes to engage in this fight, and I thank you for the opportunity to appear before you and look forward to answering any questions you have.
Assuming it's just those of us that are here, it would be in this order. I'll speak, and then Senator Durbin, and then Senator Sessions, and then Senator Klobuchar, unless Senator Tillis comes back. I'm going to start out with Director Botticelli, and I refer to the final report of the your office and DOJ co-chairing the National Heroin Task Force. There are a lot of good ideas in there to attack this epidemic for many different directions. But the task force mission statement included, among other things, creating a framework for efforts to, quote unquote, restrict heroin supply. And on this point, I have some questions because I think there's a fault in not enough attention to that. The report and recommendations didn't even mention the massive influx of heroin that's being trafficked into this country by Mexican drug cartels. They don't even mention that heroin seizures at the border have more than doubled since 2010. They don't even mention that a few weeks before the report was released, your office announced that Mexican heroin production jumped an incredible 62% from 13 to 14 years. So my question, how can it be that the National Heroin Task Force didn't even acknowledge these dramatic developments related to the supply part of the heroin problem, let alone suggest specific solutions to address it? Before you answer that, isn't it at least part of the answer to this epidemic, securing the border from Mexican cartels? And what can we do about that part of the problem?
Sure. Thank you, Senator. Let me start out by saying that I agree with many of the comments here today that focusing on supply reduction has to be part of our comprehensive response. We know that part of what we're seeing in the United States is a tremendous increase in very cheap, very pure heroin in many parts of the country where we haven't seen it before, as well as an increase in fentanyl. The task force, Senator, focused exclusively on what we could do domestically as it relates to both public health and law enforcement. But part of our national drug control strategy, part of our work in general around this issue, has been to focus on, one, how can we work with the government of Mexico to look at things like enhanced eradication, to look at taking down heroin labs, finding fentanyl labs, taking them down. We also, in October, I formed a national heroin coordination group that's been working in concert with the National Security Council to look at what additional actions that we can take, including those at the border and in other parts of the country, to reduce the flow of heroin into the United States. It has to be part of our comprehensive response to do that. So I would agree that we have to focus on our supply reduction efforts as we look at things like prevention, treatment, and recovery, because we know that that is part of what is really fueling the heroin and particularly the overdoses that we've seen with fentanyl in the United States.
I hear you say that you're dealing with it, and I respect that, but it seems to me when you have a central document like the report is, that this aspect of it should have been mentioned, and it seems to me that it could be a problem with the administration avoiding at all costs and facing this issue squarely. Mm-hmm. I'll go to Dr. Volkov. The relationship between the prescription painkiller crisis and the heroin crisis has been the subject of some specific study and debate. You touch on this in your testimony. We've heard a lot of discussion about this very day. The heart of the question is to what extent the heroin crisis is attributable to the over-prescription of painkillers and subsequent efforts to reduce diversion that may have led some users to cross over to heroin, as opposed to other factors such as the rapid increase in heroin supply over the last few years. So, question, clearly it's not an either-or situation, but could you tell us more about what the studies tell us about how much we should attribute to the heroin crisis, or attribute the heroin crisis to our experience over the last 20 years with prescription opioids?
Yes, it's not an either or. What happened was a dramatic increase in the number of prescriptions that led people to divert them and become addicted to them. In parallel, there was an increase in the entry of heroin and a resultant increase in heroin abuse by people that were addicted to prescriptions and then started to use heroin because it was more available. Indeed, however, as some of the opioid medications became more difficult to divert, some individuals transitioned to heroin because of that. But if we address the problem, the source of the heroin epidemic that we have is the addiction to prescription opioids. And if we want to address it, we need to address the abuse and diversion of prescription opioids, because it's the source, it's the origin of the heroin epidemic.
A couple other questions I had were answered in your testimony. I go to Senator Durbin.
Thanks very much, Mr. Chairman. We were just talking with members of my staff. I was trying to remember a 72-hour period in Chicago last year when I don't know if there were 74 heroin, fentanyl overdoses or deaths. It could have been deaths. It was just horrendous when it came into the supply there. And as I've mentioned earlier, I've traveled around my state. It isn't a Chicago problem. It's an American problem, sadly, in every town, large and small, that we get into. When I went to Dixon, Illinois, population 20,000, inspired by the chief of police in Gloucester, to have people step up and admit their addiction. They weren't arrested, they were taken to treatment, and petty crime in the community disappeared, virtually disappeared as a result of it. But they were saying to me, what are you going to do about treatment? You know, now that they've stepped up, now that they are acknowledging, well, it's an hour-and-a-half drive from Dixon, Illinois, to the closest treatment facility. If the person who is a user happens to have the good fortune of someone who will pay for it, a health insurance plan, a Medicaid plan, or whatever it might be. So talk to me for a moment about the treatment side of this. It strikes me that we need to dramatically increase our commitment to mental health counseling and addiction services. And I'll just add parenthetically, the fact that this is no longer an inner-city minority problem, but an American problem, predominantly a white American problem, I think creates a political force that might see this to the right conclusion. I'd welcome your comments, anyone who'd like to speak to it.
Thank you, Senator Durbin. And I would echo the sentiment of many people here that we've seen law enforcement step to the table in an incredibly dramatic way and acknowledging that we can't arrest our way out of the problem. And it's not because the police chief is sitting over my shoulder. You know, we have law enforcement agencies across this country who are now administering naloxone. And when you hear the stories that they tell about reversing people's lives, it's really amazing. The second thing is we've seen, not just in Gloucester, but we've seen that kind of program take off nationally, where police are not only saving people's lives, but accelerating. And I think we need not frustrate them by a lack of treatment availability, that we should capitalize on their goodwill. And despite, I think, all of the things that we've done collaboratively to expand treatment, even President Obama in West Virginia acknowledged the fact that we probably have a significant treatment gap here. Administrator Kanemoto talked about the fact that only about 20% of people get treatment in the United States, and that's really abysmal. We wouldn't accept that with any other disease. The last thing I'll say is, but we also have to combine that with an increase in the workforce. So we can put money out to expand treatment, but we need more physicians who are able to prescribe these medications. We'd love to work with Congress on expanding who can prescribe those, including physician assistants and nurse practitioners.
And I endorse this, and I have a measure in with Senator Markey, I believe it is, to allow physicians to dramatically expand their caseload because there's so few who are willing to take on these cases. And that is a temporary answer. The real answer is to bring in the professionals who, in the proper numbers, to deal with this epidemic that we're facing.
Yeah. I'll just say one last thing, that one of the things that we've seen with this epidemic is really just the expansion into rural parts of the United States, like Governor Shumlin talked about. So we have to really focus on those strategies that get some of those resources, some of those trained folks in rural parts of the country that don't have a dedicated treatment.
May I ask, I only have a minute left here. Going back to the earlier observation about dirty doctors who are prescribing in pain clinics things that are not needed that end up being on the street and sold into commerce here. Tell me, if you can, I don't know which one of you wants to, if you can, speak to it here. What are we doing working with the medical societies and the medical professionals? They are the gatekeepers for these prescriptions. And Senator Sessions talks about a couple drugstores. Well, it's a couple drugstores and maybe a dozen dirty docks. And now you have a city that's under siege, leading to these heroin addictions and such. And I'm wondering, what are we doing to encourage the profession to clean itself up and to police the ranks for those who are abusing it so that they're held accountable in a very public way?
I would say that a fundamental problem in all of this issue is if you think about 750 million prescriptions annually in the United States, which actually leads to an enormous amount of diversion, and 741 tons on one pickup and take back DEA day, that is clearly telling us that we are over prescribing medication. So it's not just that drug doctors, which are actually very few, but the practices that we have in order to treat pain in this country that are the main source of the prescription opioids that are being diverted and leading to addiction and overdoses.
Is there a conversation with the medical profession about this?
Yeah, sorry.
So one of the things that we have done as part of the President's trip to West Virginia, we actually worked with most of the major medical societies and gathered a commitment from them to train 500,000 of their physicians and prescribers on safe and effective opioid prescribing. From my perspective, it's not enough. And when we look at the data, and we're 10 years into this epidemic, that I don't think it's too much to ask medical professionals and medical societies to support a minimal amount of medical education as it relates to safe and effective opioid prescribing.
And I'm going to intrude here because also one of the issues, many of the guidelines that are currently available for physicians in order to train about the use of prescription opioids are actually being developed by the pharmaceutical industry. So there is a direct conflict with it. So the National Institutes of Health has actually coordinated with many institutes to generate curriculum for not just medical students and physicians, but also nurses, pharmacists, dentists, for the proper management of pain and the use of prescription opioids. And again, there's also obviously interest, and we've been working with the different medical agencies for the development of guidelines for the better management of pain.
Senator Sessions.
Thank you. This is very important. I know Senator Durbin is correct on many of those points he's made. The Association of Pain Physicians are concerned about this. They know people that are coming in complaining about pain. Many of them have other sources, other doctors giving them pain pills, and they have supported things such as allowing a physician to check through the computer system other doctors that may be providing the same relief. Mr. Botticelli, do you agree that that could be helpful? And it provides good doctors an opportunity to push back and not overprescribe.
Sure. I think these are the main goal of having good, robust prescription drug monitoring programs that are easy to use, that are interoperable across state lines, so that physicians can have good, accurate information about how many prescriptions one of their clients can be getting. It's a prime part of, I think, our strategy, and we've seen them work in many states that have implemented it and where prescribers actually use the data in the databases.
Now, Mr. Milioni, DEA has great power, it seems to me. You can monitor the number of prescriptions that are coming from any physician, can you not? That's part of your control ability?
Senator, as far as the PDMPs, those are state programs. We support all our state partners and the National Association.
But if you have information that a physician is prescribing extraordinary amounts, you can go and interview that physician. You can examine their records as part of your, you don't need a search warrant. You can just ask for their records. And a drugstore or a pharmacist you can also examine their records. Is that correct?
That's correct. Investigations can start in a number of different ways, and patterns of overprescribing and such information from other sources can lead to an investigation.
Now, if a doctor is clearly abusing, and I saw it in my community, we had some doctors and we had some pharmacists, which we didn't expect. The simple deal was the DEA and the local police chief signed a one-page memorandum in my office that nobody would have a plea bargain on a prescription drug until they told where it came from. And he came back for a very limited number of sources. And that problem of that particular drug was virtually eliminated in Alabama for a while. if somebody goes to jail, that sends a message to the other doctors and pharmacists, does it not?
Certainly it does.
I think that's important. Now, looking at the new report from the prestigious New England Journal of Medicine just a couple of months ago, they conclude there is no consistent evidence of an association between the implementation of policies related to prescription opioids and increases in the rates of heroin use or deaths, although the data is relatively sparse. Alternatively, heroin market forces, including increased accessibility, reduced price, and high purity of heroin, appear to be the major drivers of the recent increased rates of heroin use. Do you agree with that, Mr. Milligan?
Senator, we're focused both on the prescription.
No. Do you agree with that or not?
It's not a yes or no answer, Senator.
Well, it is. Mr. Botticelli, you're supposed to set drug policy for America. You're what they used to call the drug czar. Do you agree that reduced price, high purity, and increased accessibility of heroin are the major drivers of the recent increase in rates of heroin use?
So this study was actually undertaken a question that I had about what we were hearing about, does reduced availability of prescription drugs drive people to heroin, right? So there's been folks who have said, if you clamp down on heroin.
Well, look, I'm sure some do.
Yeah. No,
I don't dispute that.
But I would.
The question is, as I ask it.
Yep, I would actually agree that the availability of very cheap, very pure heroin in the United States, as well as untreated addiction, has significantly increased heroin use rates in the United States.
Well, I think that's a good answer, Mr. Chairman, and the lack of enforcement at the border is a big part of this. I'll just say this personal story. In the 1970s, I became a assistant United States attorney. I was given 17 heroin cases to prosecute. They were small ones. They didn't trust me for anything bigger. And it was almost all coming from Turkey. President Carter was very aggressive in that, and I give him credit. I came back in 1981 as United States attorney, and we went several years before we saw a heroin case. Supply is important. We can impact supply. And heroin at low prices and high purity on the streets are dangerous. And prosecutions are critical to this. And people need to go to jail who are pushing this kind of addictive power into our community, destroying lives and families and dying of overdose and destroying whole families. So, Mr. Chairman, it's a very important hearing. Thank you. We can do better about prescription drugs. Taxpayers are paying on their Medicaid, Medicare bills often. Their insurance rates are higher because of overdoses and over-prescription of prescription drugs. And it's an important issue. Thank you for your leadership.
Senator Whitehouse.
Thank you very much, Chairman. And again, my appreciation to you for holding this hearing. I think it's a terrifically important issue, as the witnesses have said, and I think the Comprehensive Addiction Recovery Act provides a real means for getting our arms around it. First, Mr. Botticelli, thank you for being here, and congratulations on the terrific 60 Minutes appearance. There I was, clicking through the channels, and next thing I know, there you are. It was really wonderful. I have to go to another event for another piece of bipartisan legislation that I'm co-authoring, and so I won't be here when Ms. Hurley testifies, but I want to welcome Linda Hurley of Rhode Island, who has been on the ground dealing with this problem for 20 years and will bring a really terrific perspective to this committee, and of course Tom Kader, my Rhode Island friend, who's now working at SAMHSA right now. I do want to ask unanimous consent that letters from the National Association of Attorneys General and the National District Attorneys Association and 126 organizations that are active in this area be admitted into the record. They're all supporting the Comprehensive Addiction Recovery Act.
Without objection, they will be included.
Thank you so much, Chairman. And finally, I assume that all of the witnesses on this panel support the Comprehensive Addiction Recovery Act, but if you could confirm that for the record, I'd appreciate it.
There is clear evidence that a comprehensive response looking at multidimensional aspects of this that are embedded in the CARE Act are tremendously important. We know we need to do more, and I think that all of those components put forward in the bill are critically important to make headway in terms of this epidemic.
Agreed? Yes, agreed.
Comprehensive program delineated, and it's one of the strategies to address the problem.
At Sampson, we are already.
Your mic's not on, Ms. Enomoto.
At SAMHSA, we're so excited to be able to implement programs like medication-assisted treatment, prevention, prescription drug, and opioid addiction, which Congress appropriated in 2015, and then another increase in 2016, which is very similar to some of the programs that were described in the CARE Act. I thank you, Senator Whitehouse, for your leadership on this issue and continued support of our mission. We believe that the public health approach of the CARE Act is vitally important to moving forward on the issue.
Senator Whitehouse, happy to work with you or anyone on any legislation that will help with this epidemic.
Very good. Thank you very much, and
Senator Tillis.
Thank you, Mr. Chair. Thank you all for being here and for your service. First, I just want to go back and say that I am happy to see that we have a growing consensus around CARA and doing what we need to do to address the problems, both in terms of the prescription drug problem and the heroin problem. And I think we also, I think it was you, Dr. Volkow, did I pronounce that correctly? Who said something that was very intriguing to me, and that was a potential heroin vaccine. And the reason I mention that is ironically, a part of the solution to the problems with these drugs that are being prescribed is relying on the very communities that may have created these and they're being dispensed improperly to come up with solutions and treatments so that we can resolve the problem. So we need to make sure, as we're trying to fix the problem with educating doctors and making sure they're being dispensed properly, that we don't disincentivize the very people that we're going to have to rely on, the communities, the research communities, the pharmacy companies, to try and come up with solutions. And I think that the policies here will be balanced and won't threaten that, but I think sometimes in the rhetoric we can demonize people who are actually a part of the solution as we get to the problems. My question for you, actually, my question, is it Milione? Milione. I'm very curious. I met with the outgoing commander last year, Commander Kelly, down at Southcom, and he was talking about how frustrated he is or was with very clear knowledge. I mean, we know where these people are. We know when they get up in the morning. A lot of times we know when boats are leaving the shores and potentially going to some place in Mexico. And yet we really haven't recognized the death toll of narco-terrorism over the past several years. Hundreds of thousands of people in the United States have died as a result of drugs coming to this country. What are your thoughts on, first off, some sense of the drugs flowing into the country? Many people think they're being manufactured and distributed out of Mexico, but what is the mix in terms of the illicit drugs, primarily heroin, that are coming maybe across the Mexican border, but their originations are somewhere other than Mexico? Roughly what's that percentage?
I couldn't give you an exact percentage, but it's going to be primarily Mexican trafficking groups that are bringing it across the southwest border. Obviously, you have some that are coming from Colombia, South America, and the source countries, but the Mexicans have taken over a great deal of that and have great distribution networks throughout our country.
Do you agree with General Kelly that a part of our strategy when we talk about border security, if we spent more time focusing on the southern border of Mexico and some sort of collaboration and providing more interdiction money, that may be a higher benefit to at least reducing the supply chains?
Senator, my whole career as an agent and what DEA focuses on are targeting networks, the cartel leaders, the link points, the distribution cells domestically. As far as in the foreign arena, we have a great overseas presence. We work with our foreign counterparts in Mexico and elsewhere. It's an ever-evolving threat, and we work with them side by side to work those cases and attack the entire network.
How would you characterize Mexico's cooperation with your efforts?
We have a great partnership in Mexico.
Good. Thank you all. In the interest of time, I'm going to yield time for the next panel.
Senator Klobuchar.
Thank you very much, Mr. Chairman. Thank you to the witnesses here. I want to start with something I mentioned when I made my opening statements here, and that is the drug take-back work that Senator Cornyn and I passed in 2010, the Secure and Responsible Drug Disposal Act. And we took a very long time, as you know, Mr. Milioni, to get those rules done, but they're finally done. And it makes it easier for some of the drug take-back programs, especially with assisted care facilities, other places. But what we'd really like to see is the pharmacies start doing this. I think that would make it much more widespread than just having it in police offices, and we have them in Minnesota in libraries in place. We're pretty ahead of the curve on this. But I still think it'd be much easier if we had them in places where people are buying drugs and bringing back things. And what do you think we could do to incentivize that, since it hasn't really been happening?
It's a great question. It's certainly a concern for us. We want to work with our interagency partners and try to find some long-term sustainable solution with private industry. Until that point, like I said in my opening statement, it would be great if drop boxes were all over the country. Until that, what we'll focus on, we'll continue doing the take-back events. It's an opportunity to get the drugs off the street, but also an opportunity to engage with the community and educate them about the link between prescription opioids and heroin. We will engage in any effort to try to expand those drop boxes.
Very good. And you want to add anything, Mr. Botticelli?
Just that I think that we thought once the regulation passed, we would see better take-up of this. We've
Right.
actually been having conversation with large pharmacy chains
Right.
to see what we can do, and also looking at, are there grant possibilities within the federal government?
Because, you know, it took 2 years to pass the bill and then 4 years to get the rules, or 5 years. And if we need more rules or another law, we can't take 6 more years as more and more people are addicted and dying. So if that's what the answer is, that the pharmacies say they need more rules or more, forceful regulations, then we should do that. But we better get it done. And if that's not what they need, I think they could just do it. Then they should do it. So I will join with you in trying to get that done. I also want to put on the record, Mr. Chairman, with your permission, the testimony from Hazelton Betty Ford, one of the leading treatment centers in the country that's based in Minnesota.
Without objection,
Thank you very much. And just talking to Dr. Marvin Sepula, who is the Chief Medical Officer at Hazelton Betty Ford, he's spoken about the need to mandate use of prescription drug monitoring programs. Mr. Botticelli, as you note in your testimony, a number of states have enacted measures to do this already. That's part of the work that Senator Ayotte and I did, the bill that we introduced that's part of this bill. Could you talk about what barriers there are to making this a reality, and if the state programs are differing, so some are more intense than others, and what we can do to move that along?
So one of the things that we've done, it's not just having those programs, it's how do physicians use them. And we have looked at, we were happy that there was additional resources this year through the Department of Justice to enhance prescription drug monitoring programs. And we're also looking at how do we accelerate the use of that information in electronic medical records to diminish the burden on a prescriber from checking various databases, as well as interstate operability. But, again, I think that what we've seen is relatively, even with good programs, relatively low utilization of prescription drug monitoring programs. So
And are you saying we need to make it more mandatory? Because we just can't have, just because people don't want to do it, and then more and more people are getting addicted and dying, that doesn't seem to be working.
I agree. I think that we've seen good success with states that have implemented mandatory use of those programs. We've seen a dramatic decrease in doctor shopping behavior when prescribers access the information.
So just making it voluntary doesn't appear to be working.
I think with the urgency of the situation, that waiting until we get more uptake on these programs is not fast enough.
Okay, and then my last question of you is just the core issue here with the governor of Vermont was talking about, with making it easier and easier, more of these products out there and getting approved for populations. What do you think needs to be done? Do we need to change the standards that the FDA uses so that they take better consideration of the risks of addiction? in terms of approving things?
My take on this, quite honestly, is that this is not just about the amount of those medications, but it's really about prescribing behavior. It's really not about are we having these drugs, it's how they are prescribed. And I go back to the study
And the amounts that they're prescribed in as well?
and the amount that they're prescribed. I go back to the study that I cited where this was not about whether or not we had an approved medication. This was about physicians who continue to prescribe in spite of the fact that someone had an overdose. That's not about how many medications.
So if you could wave a magic wand, I'm sure you'd help us with our drug take back. Okay, fine. But your number one thing would be to try to make these programs more intense, mandatory, so that the physicians have more limits and the doctor shopping stops, and so that they can have limits on how much they prescribe and when they're prescribing it.
I would absolutely agree with that.
All right, thank you.
Senator Franken.
Thank you, Mr. Chairman. I'm sorry I wasn't here for your testimony. I had some other meetings, and I was not able to read your testimony because our office didn't get it till either late last night or early this morning. This is a subject that's interested me for decades. You're just talking about prescribing, overprescription of these. One of the causes, and Senator Shaheen mentioned this, and I thought it incredibly important, is medical school. Medical school and nursing school. This has been something I have heard about for decades, and it doesn't seem to get corrected, which is that we've had addiction problems in this country for a long time. This is not new. Why don't we have in medical school mandatory instruction to our to doctors or to medical students information about what addiction is? Because we don't seem to have it. And we should have it at nursing school too. But if you have doctors prescribing and these drug monitoring programs, these prescription drug monitoring programs should be mandatory, and anytime you're prescribing an opioid, you should be having to look and see what this history is, because we know now what a serious problem is. But anybody here have a strong view on medical school and training of physicians in this country on what addiction is?
Yes, we've actually been funding several investigators to develop a curriculum for substance use disorders. And one of the big challenges for medical students has been that the medical schools say their curriculum is already too loaded and they don't have time for more questions. So we have been working actually to try to convince to have questions in your medical exam that relate to substance use disorders, because that will incentivize the medical schools to actually train medical students in the management of substance use disorders. The same strategy for pain, and we had a researcher that actually evaluated the number of hours that medical students get on the education on pain, and they found out that veterinary schools get approximately at least 5 times more hours of education on how to handle pain in animals than in humans. So we have a need on both sides. And so there
In
has
animal,
been,
they spend 5 times as much time on studying
if you're
pain.
a veterinarian, you get much more training on how to address pain than if you're a medical student.
Okay.
So the amount of time you spend training on how to screen and properly manage pain
That's
is minimal.
crazy. You know, I mean, if you look at data on, addiction has other health, causes other health problems too. And a lot of what people come into the doctor's office with is the result of addiction. And if the doctor understood that, we'd be, this isn't just about ODs. This is about other diseases too. And this is something that has been vexing me for a long, long time. I want to just touch on a couple things, and I won't have enough time here, but we talk about this affecting rural white people. It's also in Minnesota, big time, our American Indian population. And there is an epidemic. Only 2% of Minnesota's population is Native American, but Native American babies represent over 28% of babies born addicted to opioids. and we need to address that. And we've seen some good things. Hennepin County has a project that has reduced the number of children born in withdrawal. And I was wondering what strategies anybody has to close this gap that we have between the need in rural communities and in Indian communities and the available resources, which brings me to the other question that I have, which is how are we going to gear up treatment when only 20% of people who have addiction can get treated?
Yeah, when we address the problem of neonatal abstinence syndrome, which is the syndrome of children being born out of women that have been given opiates, we have to distinguish two different sources. One of them are women that are pregnant and they have pain and are prescribed an opioid medication during their pregnancy. And in the United States, it's 18 to 24% of pregnant women will receive an opioid medication during their pregnancy. If they are getting in towards the last trimester, that increases the likelihood that they will have a child with a neonatal abstinence syndrome. And then you have the other women that are addicted to heroin or to opioid prescription medication that if they are not properly treated, will have a severe case of a neonatal abstinence syndrome. So the interventions are different. One of the questions that the medical community is raising is, do you need to have so many prescriptions of opioid in pregnant women? And the consensus is that you probably should only give it under very unique situations and avoid them. The second one is that studies have shown that treatment with either methadone or buprenorphine on patients that are addicted to heroin actually improves the outcomes to the mother and to the baby. And third, the other item that is important is, regardless of what drives ultimately the neonatal abstinence syndrome, the importance of training physicians in order to recognize someone that is at high risk of having an infant with a neonatal abstinence syndrome so you can intervene. Because if you don't intervene, that newborn can die.
Senator Coons.
Thank you, Chairman Grassley. Thank you for convening this hearing, and I'd like to thank my colleagues for their very active engagement. Let me move, if I might, directly to a question of Director Botticelli from the Office of National Drug Control Policy. I was very pleased last summer to see my home community of Newcastle County, Delaware, added to the Philadelphia-Camden HIDTA, the high-intensity drug trafficking area. And I know you've personally visited my state, my county, and you recognize it, like so many other states and communities, is facing a very real challenge in terms of the increased frequency and intensity of prescription drug abuse and heroin addiction. And in August, as part of your heroin response strategy, the Philadelphia-Camden HIDTA received additional funding to place drug intelligence officers and drug policy analysts in Pennsylvania and Delaware. I'd be interested in an update on how you think these efforts are working, how they're working in the other 5 regional HIDTAs, and how you see your larger strategy by ONDCP of adding additional law enforcement personnel faring, and how this helps state and local law enforcement have the skills and the ability and the strength they need to really tackle this very difficult challenge.
Thank you for that comment, and I was really pleased to be able to announce that. I think that having the resources to look at increasing high drug trafficking areas in the United States is particularly important, so we're grateful that we have the resources to do that. But our HIDTA programs also understand, like the DEA, that it needs to be part of a comprehensive response. And the additional dollars that we were able to give, not just for law enforcement intelligence, but also for public health coordinators to work in a comprehensive way to diminish the supply, but also have that robust community response to be able to do that. I'm actually, our HIDTA folks are in town next week, and I'm actually getting a briefing from them on the HIDTA response strategy. So I'll be happy to provide you with an update in terms of where they are, what their measures they've looked at, and how we might continue to focus on both the law enforcement and public health aspect to that.
Well, I'd welcome that and appreciate it. I do think we need a combined strategy that's both law enforcement and public health. The CARA bill that's been referenced so broadly in this hearing is one I was proud to join as a co-sponsor. I do think we need a comprehensive strategy, but I'd be interested, Mr. Milione and Director Botticelli, if you'd comment on when the DEA has additional resources, as it should, to interface with state and local law enforcement, How do we sustain that over time? How do we recognize that this is not just sort of a temporary or transitory problem? It's one that we're going to need both additional public health and law enforcement resources for quite some time. How can we better support valuable programs like these in Congress? Mr. Milione?
Senator, the task force concept has been DEA's bread and butter for decades. So we welcome and engage with our state and local counterparts. So if it has to do with the heroin threat or the prescription opioid threat, we will continue to do what we've done, attack the networks. Any resources certainly will help us. We value those relationships and we'll continue down that path.
You know, I think one of the values, so having and continuing to build on the HIDTA infrastructure becomes really important, and not just around the heroin and opioid epidemic. I think one of the things that has impressed me about our HIDTA programs is their nimbleness in terms of being able to really focus on whatever an emerging drug threat is. You know, we're talking about heroin and opioids, but in many parts of the country, meth continues to be a problem. We've had an increase in new psychoactive substances that we've seen. So it allows our HIDTAs at a very local level to focus on those issues that are important and to really be able to move toward those evolving trends. So, you know, and obviously having state and local as part of their board and part of their structure are incredibly important to the HIDTA management.
Last question, if I might, Dr. Volkow and Ms. Inamoto. Do we in the public health sector have the same sustained coordination around the provision of public health services at the state and county level that we've moved towards in law enforcement? And what more do we need to do to get to a strategy that's going to address this issue for the long term? Doctor?
Yeah, the implementation actually of public health policies varies by state. So, for example, even the implementation of medication-assisted therapy differs enormously.
Right.
And whereas in some states it actually follows that you don't have to have a whole series of roadblocks in order to get the medications. In other, it is very difficult to get the medications, and also you are limited to a certain amount of time. So it is not as well integrated. Similarly, the integration of the healthcare system with a specialized treatment varies enormously from state to state, as well as the involvement of the healthcare system with individuals that go from the criminal justice system out into the community. So there's not a consensus on how these states are managing it.
Ms. Inamoto?
I would say that our state and county leaders within the field of behavioral health are acutely aware of their need to partner with their law enforcement, their Medicaid, their veterans, their labor counterparts. And so throughout all of SAMHSA's programs, and I know many of the programs of my fellow HHS operating divisions, encourage that and or require that in order to get the federal funding to mirror the kind of collaboration that we've developed at the federal level, both interagency as well as within the department. We're encouraging our states, counties, localities to do the same.
Well, thank you. I'd like to thank the panel both for your testimony today and for your leadership in this very pressing and difficult issue. And I'm hoping that Chief Willard of Manchester also has an opportunity today to talk to the vital role that state and local law enforcement plays in sustaining our progress towards reducing America's dependency on opioids and heroin. Thank you, Mr. Chairman.
And I, too, thank the panel for your testimony, and I'll dismiss you at this point. And while you're leaving, I will read the next panel and final panel. Chief Nick Willard is Chief of Police, Manchester, New Hampshire, the largest city in that state. He has made attacking the opioid epidemic a hallmark of his tenure as chief. Prior to being named chief last year, he served in various capacities in that department since 1992. Prior to that, Chief Willard served in the U.S. Air Force as a security policeman. He has a degree in criminal justice from the New Hampshire Technical Institute and is also a graduate of the FBI National Academy. The second witness we've heard Senator Portman speak of 2 or 3 times, Tanya DeRay. After losing her daughter Holly to a heroin overdose in 2014, she founded Holly's Song of Hope, a nonprofit group dedicated to providing community support and education for those struggling with addiction. Since that time, she has also been an outspoken community leader seeking solutions to this epidemic. Ms. DeRay has traveled here today from her hometown, Carrollton, Ohio. Our final witness, Linda Hurley. Ms. Hurley is Chief Operating Officer, Director of Clinical Services at Kodak, a nonprofit behavioral health and addiction treatment provider. She's been working in substance abuse treatment and behavioral health care for more than 20 years and has been at Kodak since 1993. She received her BA from Newman College and a master's degree in human development from Salve Regina University. And in the case of Ms. Hurley, we've had acclamations from Senator Whitehouse for you. I'll start with Chief Willard.
Thank you, Senator Grassley, and distinguished members of the panel. Before I begin my remarks today, because I'm going to be talking about something that's really kind of consuming the state of New Hampshire, and with the eyes of the First in the Nation primary upon us, I think it's important for me to note that the city of Manchester is a vibrant, exciting city with engaged, compassionate citizenry. They have an incredible strength and a connectivity that I'm proud to serve in that community. Moreover, I think it's also important for the messaging to be that the state of New Hampshire is still an incredible, beautiful state with mountains, rivers, lakes, the ocean. So I don't want to give the impression that the state of New Hampshire is, falling into the abyss. Yes, we are dealing with the throes of human tragedies every day, but it's still a wonderful state. And please come by and spend your dollars, and tourism is still alive and well. But thank you for the invitation, Senator, to appear before the committee today. It is an honor to be able to share with you what my officers are dealing with on a daily basis. With the prescription and opiate heroin issues. In addition to the ever-increasing role of fentanyl in the fatal overdoses has been alarming. I want to also thank Senators Whitehouse, Portman, Ayotte, Klobuchar for their leadership on the Comprehensive Addiction and Recovery Act. I fully support it. What law enforcement needs is a comprehensive and sustained approach to help prevention efforts, improve treatment, support the individuals in recovery, and adequate resources for state and local law enforcement who are on the front lines of this public safety crisis every day. The bill represents a huge step in the right direction, and I hope the committee will pass this legislation. It's very much akin to some of the work that we've done locally with the continuum of care in the city of Manchester, when I partnered with the fire chief and the health director, and we worked on a lot of the same initiatives that I see in that bill. So I would encourage that you pass it. I think it's exceptional legislation. In 2013, the city of Manchester had, I don't want to get to fentanyl because we really haven't talked about it, but fentanyl is what's killing our citizens. In 2013, the city of Manchester had 14 overdoses. 30% of those overdoses were heroin. 7% of those overdoses were heroin mixed with fentanyl. In 2014, we experienced 19 fatal overdoses, 22 of which were heroin, 22 of which were heroin mixed with fentanyl, and 21 was strictly fentanyl alone. And then we go into 2015, when we see an exceptional uptick in fentanyl overdoses. In 2015, we suffered, in the city of Manchester, 69 fatal overdoses, with a staggering 33% being straight fentanyl, 26% being fentanyl mixed with cocaine, and another 9% being fentanyl mixed with heroin. So in 2013, heroin was what was killing our citizens. In 2015, it's fentanyl. Our citizens are dying because of the synthetic fentanyl labs that are being produced in Mexico by the Sinaloa cartel. The poison the cartel is putting on the streets of America is an affront to our way of life. Not only is it taking lives, it's deteriorating communities, devastating families, and leaving children without parents. We have case after case where toddlers, children, 10-year-olds are finding their parents dead from a drug overdose. And I have to say, to have an American actor go and celebrate and romanticize with the very drug cartel kingpin that's poisoning our citizens and killing them is disturbing. Senator Ayotte noted in her testimony the Stop Trafficking in Fentanyl Act, which would bring parity to the penalties of trafficking in heroin and much more deadly fentanyl. I encourage the committee to pass that bill, which would enhance law enforcement's efforts to remove fentanyl from our streets and, more appropriately, prosecute those who are trafficking in it. Recently, we just passed a bill to strengthen sentences for drug dealers who manufacture and dispense fentanyl on the streets of New Hampshire. When I took over as chief, I expressed that I had two priorities: to deal with the heroin and now fentanyl issue, and support and boost the morale among the rank of officers within the Manchester Police Department, given how taxed they are with all the calls that they're going to day in and day out, and the negativity that I'm seeing in the media about law enforcement. Well, those two priorities are effectively irrelated at this point. Officers are going out there every day trying to save lives and trying to make this community safe, in spite of the national discord. Today, far too often, fentanyl and heroin are at the direct or indirect cause of any one public safety health issue in the city of Manchester. When you look at the numbers of how taxed our officers have been, in 2013, officers responded to 166 overdose calls for service. In 2014, they went to 406 overdose calls. In 2015, Manchester police officers responded to 616 overdose calls in the city of Manchester, with 69 fatalities. Countless, hundreds, have been saved through the administration of Narcan. Each one of these numbers, folks, represents a person, a human being. And from that person that it represents, you have the peripheral victims, the families, the loved ones, the coworkers, the people that are even being victimized by the people that love them most. I don't need to tell everybody this. I'm sure you know it. We've heard what you and Senator Leahy, your opening statements, told me and filled me with a sense of pride that you understand it. I didn't believe anybody did, to be frank with you. But to hear the opening statement by you and Senator Leahy, I was encouraged that we are on the right track. To hear the Q&A from each one of you senators tells me we are on the right track. So I actually am going to leave here emboldened that we're doing the right things for the right reasons. When I have two senators from the state of New Hampshire, like Kelly Ayotte and Senator Jeanne Shaheen, and how passionate they are to protect lives in the state of New Hampshire, I live in the best state in the union. Sorry, I have a tendency to go off the rails, by the way. I don't stick with my statement. The assistant chief want to make sure I stay good, though. So after previously testifying in front of Senator Ayotte and Senator Shaheen, what we did in Manchester is we partnered with the federal government and local law enforcement, and we created an OCDETF strike force that's going to go after the cartels that our American actors want to romanticize. But we're going to go after the head of the snake through the OCDETF task force, and that's partnering with local and federal agencies, working collaboratively with a prosecutor to go after them. But additionally, and I know some questions were asked, we're going to go after the dirty doctors, because the doctors are playing in a role. And it's unfortunate that Senator Sessions is not here, because I would love to answer his question about the New England Journal of Medicine. I'd answer it directly. I think it's nonsense. I don't know what their methodology was, but I think it's absolute nonsense. When New Hampshire, Maine, and Vermont are the top 3 states in prescription of the top 5 pain medications, and those same, per capita, and those same 3 states are in the top 5 in heroin abuse, I don't know what methodology they use, but it's certainly not common sense. So after previously testifying, we did that. I've also, locally, I've invited the DEA and the New Hampshire State Police to come into the city of Manchester and to work collaboratively to have a force multiplier, in essence, to go after the quality of life drug dealers. So in all your communities, the person that's inside the 3rd floor apartment pumping heroin out of their apartment, they're bringing in undesirables, they're bringing in prostitution, they're bringing in people that are now breaking into your cars en route to that drug house. I want to shut those down in real time. So at this point, we take DEA, State Police, and Manchester Police Department, and we hit the streets trying to make buys, and as soon as we make a buy, we arrest the person, we get a warrant, we go in the house. What we don't do is do these elongated investigations in which we allow them to continue to work in the neighborhood. So we've done 6 of these operations. We arrested 62 drug dealers. We've seized 604 grams of heroin and a large quantity of other drugs. Just recently, our drug unit seized over 500 grams of pure fentanyl. Now, every one of those grams, every granule of that fentanyl is a potential overdose, is a potential fatality. And before that, from just one investigation, working in collaboration with the DEA and our local partners, In one investigation, we seized over 27,000 grams of heroin and fentanyl. 15 kilos of that was pure fentanyl. And that was in 2015. In all of 2013, the most the Manchester Police Department had ever seized in heroin was 1,300 grams. I mean, that is a stark increase. So the addiction pool, I agree, it needs to shrink because we need to lessen the demand. But the supply, most urgently, needs to be reduced with greater interdiction efforts. I'll say it, our border is a sieve, okay? The Mexican border is a sieve, and drugs are coming across that border in droves. And yes, the DEA is doing a phenomenal job because I think they, like you said, Senator, they've taken twice as amount of drugs off the street since 2010. But there's even more out there. Because when we can take 27 grams of heroin off the street, and the next night we go out and we buy another 33 fingers, which is 10 grams per finger of heroin, that tells me that we're not even putting a finger in a dike. So we must do more, and we must do it now. At the same time, you must recognize this problem for what it is, a public safety issue. It certainly has been said before, but we can't arrest our way out of this crime. Treatment and support for recovery are critical to our work in law enforcement. Last summer, the City of Manchester, through the leadership of Mayor Ted Gatsas, launched a comprehensive plan to confront this epidemic. And it's very much like Cara. One part of the plan was to develop a continuum of care by mapping all community assets devoted to drug addiction, allowing someone struggling with addiction to enter the system at any point during the continuum. We are also making great strides, and I'm almost done. We are also making great strides in our 24-hour care of continuum facility. I've heard talk about the Gloucester model. I think eventually this is going to be the Manchester model. And what this is, it's the great folks, the Hope for New Hampshire. It's going to be a 24-hour facility that's going to house medical, counseling, recovery coaches. It's going to have beds for transitional families. It's going to be in one location. And what is that going to allow me to do? It's going to allow me to, my apartment, to have a more compassionate alternative to an arrest. So I can actually bring some of these folks directly to the facility. They will actually drive out to the location of a police officer and give them a ride to the facility in lieu of an arrest. So I think that is going to be the model. You don't need to come to the Manchester Police Department to give us your drugs and then get treatment. We're actually going to have a car come out and get you and bring you directly to a facility, and you bypass law enforcement altogether. And finally, I will continue to be aggressive to fight and rid the City of Manchester of drugs while supporting the recovery and treatment community with everything that I have. This is not just a law enforcement issue, it's a community issue. And as a community, we will prevail through tireless action. Thank you, sir.
Your commercial for New Hampshire, first in the nation, primary, I heard all those nice adjectives. They all apply to Iowa.
Indeed they do, sir.
Ms. DeRay.
I just want to say thank you so very much for giving me...
Is your microphone on?
Yeah.
Would you, yeah, thank you for getting a little closer.
Thank you for giving me the opportunity to share my story here today. I am not certified, educated, diplomas, and everything else. I had a lot of stats. I know a lot of stats, like everybody else does. And I'm not going to go off of my statement. But I will keep this short. I want to fill in a few blanks from what I've heard today. There's been some great information put out here. Every day I speak with and deal with people who are in active addiction, people in recovery, and families of those in recovery. And a few different things that I've seen that maybe didn't get covered here that I feel is important to keep in mind are the cost. It's been said many times that heroin is cheap. But believe it or not, I believe a lot of, especially parents, don't understand how cheap. And I think that's very important for them to know. Parents don't realize that when you give your kid $20 to go to the movies on a Friday night, you could have easily bought heroin for them with that $20. And I think that's really important to get out there. Another thing that I know, because I live in a very small community. My county is under 30,000, Carroll County, Ohio. I live in Carrollton. We have a small town. We don't even have a Walmart. No hospital. A lot of our law enforcement went to school with my girls. My oldest, Miranda, is 26, has already done 4 years in the Navy, and now has her bachelor's in business. And one of the things that I see happening in our little town that frustrates me is, you were saying disconnect. Our officers have worked so diligently to arrest people that they know are bringing this in, just to have them go in front of our judges, and our judges to slap these people on the wrist and send them right back out the door. And I can't tell you how often I get these boys that I consider sons because I've watched them grow up. People say, oh, they're terrible, they're not doing anything at all, and give them such a bad rap, and that frustrates me because I watch them. They're busting their butts, but what do you expect them to do when they keep arresting the same people and sending them in front of these judges for the judges to turn around and put them right back out on the street? The boy that sold my daughter the heroin that killed her just recently went back in front of a judge for his 4th offense for trafficking heroin. 4th time he's been arrested for this, and he was given 5 months. How's that possible? That's so frustrating. It frustrates me, of course, but I can't even imagine what our law enforcement deals with in that situation. You know, these are things that have to be dealt with. And then lastly, what do I know? Miranda Ray changed channel or something. I know that when you find your 21-year-old on the floor, blue, with bruises already on her forehead and her nose from slamming into the sink because she died so fast, that sticks with you for the rest of your life. That when you do CPR, praying for someone to show up and help your child, and your arms are burning because you've done it for so long waiting on help. And you want to quit, but you can't quit. It's your child. That's your baby. You can't stop. The sound of my air going into her lungs, that crackling and popping that I still hear in my nightmares. We have to put a face to this. We have to help these kids. When they say, I want to quit, I need help, we can't say to them, I'm sorry. Give us 2-3 weeks and get back to us. This legislation, Kara, gives me a little hope. Please, please do something to help our children. Thank you.
Thank you, Mr. Ray. Thank you very much. Thank you. Ms. Hurley.
Excuse me.
Thank you so much. Much of what I have included in the
Would
testimony.
you pull the microphone in front of you?
I can. Is that better, sir?
Yeah, thank you.
Okay, sure. First off, too, I would like to thank you for this opportunity. I've been in the treatment field for over 26 years, and I was asked to participate today to provide the perspective of kind of like what it's like where the rubber hits the road. What do the problems look like? What do the challenges look like? So I'm going to quickly skim through the statistics that everyone has heard over and over, as astounding as they are, and get to the complexity of the disease and what is needed. So I may not correlate completely to the testimony that you have right now. The opioid overdose death epidemic has resulted in an average, as you have said, of 125 people daily in this country. In 2004, it continues to grow. Since 2002, rates of heroin addiction have doubled, and heroin-related overdose deaths have nearly quadrupled in the United States. The rate of opioid pain medication prescription has increased dramatically. New vulnerable populations are emerging. Parts of our country are faced with limited or no resources to assist those needing care. Midwest states, our Northeast. Infectious disease such as HIV/AIDS is again on the rise, and Hep C numbers have increased at alarming rates. The disease of addiction, this chronic, relapsing, and often permanent disease of the brain, is costing taxpayer dollars, costing lives, and causing society to lose the creativity, the individual contributions that each lost life represents. It is replacing those contributions with fear and grief. The pain, distress, and stress that are the result of lost lives have permeated our communities and have become a part of the problem. My understanding and daily 26-year experience in the treatment of this disease and its related tragedies is the reason I am honored to have been invited to participate in the conversation today. From the treatment perspective, I've been asked to speak on the issues of the prevalence that supports the need for prevention and treatment, what populations are being most affected by this disease, what are the treatment needs of those individuals and families, and what challenges do we face in meeting those needs in 5 minutes. The growing numbers of those with opioid use disorder, also called opioid dependence or addiction, reflect new trends in those who are becoming addicted to opiates. This is critical when we're creating effective treatment modalities to assist the people that are coming to us for care. The traditional bell curve of an opioid-dependent individual coming to treatment has historically reflected an age of 39 to 42, 30% female, 70% male, much more urban than rural, of lower incomes, education, and health supports. There has been a conspicuous shift in these demographics between 2004 and 2014. I believe Senator Durbin referenced the CDC mortality rates for white middle-aged populations. There's also mortality rates that are changing in the mortality rates for young white adults. These numbers correspond to increases in emergency room visits, recorded treatment episodes, and police data, all reflective of opioid use. What we're seeing is an increase in opioid dependence in younger and older white populations, rural populations, and female populations. Emerging or growing vulnerable populations are women, young adults, adolescents, middle-aged adults, returning vets, those receiving multiple co-prescriptions, patients receiving care for chronic pain, including the elderly, and at very high risk, those in the criminal justice system. I don't believe it leaves a lot of us out there that aren't impacted by this. The disease no longer follows gender, race, age, or socioeconomic boundaries. The challenge of treating multiple populations is in providing care that is individualized, effective, and evidence-based for each of the populations. Cognitive and emotional development, stage of reproductive life, cultural norms, experience of multiple forms of trauma, the individual's readiness for change, their strengths, their resiliencies, and the recovery supports are just some of the clinical variables that need to be addressed in providing successful treatment. Over 50% of those who come to treatment come with at least one other mental health or psychiatric condition, as well as multiple physical conditions. Most commonly, forms of depression, anxiety, and other manifestations of trauma. This is a highly complex biological, psychological, social, and spiritual disease. to be prepared to address the complexity with competence, treatment providers, physicians, and please, independent licensed practitioners, our PAs and our nurse practitioners and counselors need knowledge of treatment options, compassion, and a clear understanding of the neuroscience of addiction. Medication-assisted treatment for opioid dependence has been the most effective research and regulated evidence-based treatment for this disease. The pharmacological intervention using methadone is an established practice that has assisted individuals in regaining their lives from opioid dependence for over 50 years. It works by replacing the heroin of the heroin or prescribed opioids on the receptor sites in the areas of the brain affected by those opiates. Science has shown us over and over again that replacement therapy works with competent concurrent behavioral health counseling. The correct dosage of medication allows an individual to not feel the extreme pain of withdrawal, but also does not provide the euphoria or high associated with misuse and dependence. This, in turn, provides the individual the opportunity to heal physically, emotionally, and spiritually. I'll jump ahead here. Medication-assisted therapy can preserve life and allow an individual to work on their recovery. Sustained long-term recovery ideally includes health, home, community, and a purpose. A medication addresses none of these, but allows an individual to work on all of these. Buprenorphine is a partial replacement therapy developed to address opioid dependence. It's extremely effective, particularly in populations more physiologically naive, those that haven't used as long or as much, where the brain change has not been as severe or as permanent. The assessment process to determine which medication is indicated requires a deep understanding of the disease. Buprenorphine is well researched and now evidence-based. It is not heavily regulated, and it is attainable like any other medication through a primary care physician's office. This can dramatically increase accessibility. However, at the same time, these less stringent regulations do not require the same level of expertise. Physicians are only required an 8-hour training to prescribe buprenorphine. And that speaks to the need, again, that you've all spoken to some attention to this in the medical schools and nursing areas. It is here that another challenge to confront this epidemic arises. Clearly, we need more accessible, effective treatment, but there's no magic wand. Providing only medication will not be successful for the majority of patients receiving MAT. We need more prescribing physicians and practitioners knowledgeable in the specialty of addiction. Another medication that has been recently used is what's called depot naltrexone, and it is a medication that blocks the drug's euphoric effects, basically. That medication works really well in populations that show a high amount of motivation, because you have to be motivated to take it, to not have the euphoria. Therefore, if you're experiencing cravings, it doesn't work for you. Complicating matters, there continues to be a social veil of moral judgment stigmatizing this disease. Those who come for care and even those who provide care. The stigma can be seen in the regulation of methadone treatment and those environments in which it's provided. The regulation appears to reflect the stigma attached to the population for whom it was created. The harsh laws incarcerating individuals for symptoms of their disease versus assisting them in rehabilitation and recovery fill our prisons and destroy lives. I'll just jump ahead here as well. This practice, which has resulted in the U.S. having the highest incarceration rate in the world, is widely known to be ineffective at reducing drug use with high rates of relapse, crime, and reincarceration. Stigma is also reflected in the ongoing struggle with the implementation of mental health and substance misuse parity and reimbursement rates. This is a critical issue when we're talking about someone coming to the door and saying, I need care. Often, unattainable or difficulty attaining authorization to provide care creates a significant barrier to treatment, and this is for folks who have Medicaid, who have the benefit of the Affordable Care Act, and have the benefit of insurance. Often, families and individuals do not have the resources to advocate for themselves and their loved ones. Treatment providers do not have the staff hours to assist in this, and low reimbursement rates paralyze provider, and the complexity of the benefit utilization paralyzes consumer. In addition, I will skip the next In addition to this challenge of stigma, we see challenges to meeting the growing needs of the growing population, inaccessibility geographically and financially, inadequate treatment capacity, and inadequate provider competency. I really can't say that enough. We are not developing our workforce quickly enough, and we are not paying them enough to allow them to stay. If we can build on what we know works, hold our systems accountable to the best practice standards, reimburse at a realistic rate, and continue to build an easily accessible continuum of care, we can reverse this societal crisis. I was asked to speak also to prevention, which I will speak to briefly here, because much of what is here was already stated in terms of physician education and the surge of prescriptions. One piece that hasn't been stated and is deadly is that concurrently with the surge in opioid prescription medication, there has been a rise in the prescription of benzodiazepine for anxiety and other sedative hypnotic needs. In 2014 and 15 in Rhode Island, 33% of those receiving opioid prescriptions were co-prescribed benzodiazepines. This is a tremendous, tremendous deadly combination and has been a significant variable in the increase in opioid overdose deaths in Rhode Island, and the statistics show nationally. So along with fentanyl, we need to look at the the co-prescription of benzodiazepine. Other strategies for the prevention of initiation include, but are not limited to, patient education and the use and storage of medication, family education, continued public health education venues, and the use of community peer recovery resources. Treatment within a recovery-oriented system of care, individualized for the patient, that is easily accessible, can prevent the progression of the disease and the possibility of overdose. And I can skip here the naloxone piece. I'm quoting directly here from the Rhode Island Governor's Overdose Prevention and Intervention Task Force. This is a dynamic epidemic exposing the need for collaborations between public health, public safety, and behavioral health, reaching into the medical, pharmacy, harm reduction, and recovery communities, and in partnership with civil society representing a communal call for action. This, for me, is one of the most exciting parts of the CARA bill itself, is that there is the piece there that mandates interagency collaboration. And I believe that the interagency collaboration is going to be able to start to remove some of the silos created by funding streams. It's a huge reason that we have the silos that we do. And that's going to create the foundation for an answer to this. So I also, and I know that I represent the task force and those of us in Rhode Island providing treatment, strongly, strongly support CARA and its focus on interagency collaboration. Thank you.
I have three questions, one for each of you. I'm going to start with Ms. DeRay. And thank you for sharing your tragedy with us. I know, and we could tell that it isn't easy for you to do that, but you haven't given up, and I thought we ought to give you an opportunity for you to tell us about Holly's Song of Hope, and in particular how the organization works to provide community support for those struggling in addiction.
A lot of people say, Tonda, you're so strong, how do you do all this? Well, it's not strength, it's that fight or flight, and to get off the couch in the mornings or get out of bed and not lay there and cry all day. I realized that what was lacking when I was going through everything after losing Holly was family support. There's tons and tons of programs out there for those who are caught in the depths of this disease and fighting it, but the family support is greatly lacking. And the little bit that I did find, that I was going to get charged for, and I thought that was ridiculous. However, I'd also realized that I didn't tend to really appreciate somebody else talking to me unless they'd been there and been through it. so that they truly understood where I was coming from. And so it just made sense for me to offer that to others. We started Holly's Song of Hope on Facebook just as a group for friends and family to have memories to post memories about Holly, and maybe what things were going on with this heroin epidemic and things like that. Somehow, in under a year's time, I ended up with 1,000 members, and very active members. And I realized, yeah, this is something that we need. I mean, members from Australia and Scotland and Ireland, as well as across the United States. And we started posting questions every couple of days that have to do with addiction and, you know, in some form or another, so that people are constantly learning as well as getting support. And I had so many people saying, you know, you really need to take this outside of Facebook. And so I started talking to members, and they started sending me, I want. And I'm currently working with just under 50 different facilitators in states all across the United States, looking to start their own chapters. I started actual meetings in Carroll County. They run every other week at this point. We cover codependency. We, you know, or enabling, those two do go hand in hand. I cover a street drug of some sort, make sure that the people that come to the meetings see what it really looks like and what they need, what signs they need to pay attention to, and different, how much it costs, so on and so forth. I firmly believe education is what's going to change every single piece of this puzzle, every single one. We hear about educating the doctors. We need to educate the families. The stigma, education's the only thing that's going to change that stigma. I can't tell you how often every single day I'm sure there's going to be some story on this. And if you go and you look in the comments, you're going to see a lot of people who are going to say to me, well, if you'd have done your job as a parent and raised your kid right, your child wouldn't be dead. Well, let me give you a for instance. In the 5th grade, my daughter was going to a sleepover that one weekend, and she came to me and said, Mom, one of the girls got a joint for that sleepover this weekend, and I'm scared to death. I don't know what to do. I don't want to narc anybody out, but I don't, and absolutely, don't worry, you're not going. And I will, you know, I'll give you a good excuse. Something came up, you know, that we didn't expect. I would have never went to my mother and said something like that. I don't know how many people in here would have went to their mother and openly said something like that. We talk to our kids, our girls, all the time. There was no taboo issues. We discussed very honestly and open with them. You know, I thought I had done good, and you know, all those parent markers that you were a good parent. Got them both through school, no trouble with the law, no pregnancies, no drugs, no, you know, they both graduated. They were very popular in school for different reasons, but loved by, you know, all of their classmates. My oldest went into the Navy, and she's now a veteran, you know, and boom, I have a child laying dead on the floor.
Thank you for that. Senator Franken.
Mr. Ray, thank you for sharing your experience and your strength and your hope. and for what you're doing. Ms. Hurley, you're on the treatment side. You talked about a number of things. Workforce. We need to obviously train providers. My understanding is about 21% of people who need treatment get it. You talked about, Senator Durbin talked earlier about the Wellstone Domenici Act, which is Mental Health Parity and Addiction Equity Act. You talked about problems with having parity in reimbursement and about insurance, the low reimbursement rate about insurance companies on this. Can you talk about this area, about what we need to do to meet the needs that we have of people who need treatment, and what we should be doing, and where we're not, what barriers there are to meeting this need?
I think everyone has spoken on what's needed of the medical community, I think, at this point, and that's the training and to increase capacity. And one of the methods by which to increase capacity, and I will say it again, is for someone to please hear that the independently licensed practitioners be allowed to prescribe medication for opioid dependence. That would increase capacity with training that would also correlate to competency, because I can't say often enough how complex this disease is. It's not just biological, psychological, spiritual, emotional. In terms of I can use the COO side of my head here, the operational side. Reimbursement rates have historically been lower than other mental health rates for substance abuse. So, and that continues. You can look at any formulation of reimbursement rates for either commercial or Medicaid. Medicare is an area in which we desperately need.
And how is that determined? How are the reimbursement rates determined? Because, I mean, if someone goes into a hospital for a cancer treatment, they get reimbursed, and there isn't anyone going, well, it's their fault, they have cancer.
Right.
What seems to be going on? What's the justification, but also what is as a COO, what's going on the other side in the insurance industry and in terms of the federal government and state governments on this reimbursement?
Okay, we can start with Medicaid, and each state is different. And I believe that the Medicaid rates have been historically lower than other commercial insurance providers' rates. And what ends up happening, particularly in the behavioral health side, is we very often have a very high percentage of those who are Medicaid eligible. Therefore, a treatment facility is going to have anywhere from 60 to 90% of the folks that are coming to us for care reimbursed at a Medicaid rate. Okay, the Medicaid rates are not negotiable. They are issued through Health and Human Services in each state. We choose to do the best we can with those and stay committed to our missions, most of us. On the commercial side, there are negotiations that go on over and over. We don't have a lot of juice. We simply don't in those negotiations, and we haven't historically. I've been part of this in one way or another for 20-some years. We don't. So that's the real issue. And then the result of...
Let me just ask, and I know I'm running out of time.
I'm sorry I missed your questions. I didn't...
No, you didn't. You're speaking to the question.
Okay.
I'm just, Medicaid obviously reimburses lower than some private in other areas too. But is there a particular disparity between the actual costs and the reimbursement in recovery, in rehab?
Yes.
Okay, that's what I wanted to know, and we've run out of time. I think that's interesting and something that should
Not
be
quite the word
addressed.
I use, but thank you.
Yeah. Okay, thank you, Mr. Chairman, and thank you all.
Thank you. Chief Willard, I used to live in Manchester, New Hampshire. I'm now down in North Carolina, and like Senator Grassley, a lot of the adjectives you use for New Hampshire, I would attribute to North Carolina. We're just a lot further away from the Arctic Circle. But it's a beautiful place, and you should be proud of it. And I'm glad that you pointed out that it's a thriving state and community with this challenge that's not unique to New Hampshire. One question I have for you as a chief, what sorts of obstacles are either the federal government, in this case, I won't speak to state issues, but what kinds of things have you seen as a matter of policy here that are either helping you or give you pause in terms of taking this fight into local law enforcement?
Well, the relationships that we have with the federal agencies in New Hampshire are really robust. I am concerned with the recent DOJ decision to freeze forfeit assets.
Why I asked the question.
Forfeiture, and I understand that it's a hot button issue down here in D.C. And I've read some articles about some law enforcement agencies that have maybe abused the practice of it. But I think there should be oversight as opposed to shutting it down and having this conversation that it's not being used properly. So what does drug forfeiture look like for the Manchester Police Department? I use drug forfeiture money to fund my drug unit. That means I have an off-site, so I have a location away from the police department I pay monthly rent on. All of the undercover vehicles that we have, I pay monthly leases on. All the equipment that the drug investigators use, surveillance equipment, cameras, any sort of the specialized stuff that they need, covert mics so nobody knows that they're actually mic'd up. All that stuff costs money, and I take it directly out of the drug forfeiture money. So I'm using a drug dealer's money, his ill-gotten gains, to do drug investigations. Now, there's even a push in the state of New Hampshire now to take all of that money and put it into the general fund. And at such a time, it's unfathomable for me to think that they would do that when we're in the throes of this heroin pandemic. I think Senator Shaheen nailed it. It's a pandemic. So what would it look like if the DOJ doesn't open up this money? And I hope the split stays the same. I hope they don't diminish that split. And if the state of New Hampshire does the same thing. So the Manchester Police Department has two decisions. I have to shut down my drug investigations because I can't afford it out of my budget. The city of Manchester has a tax cap, so I can only do so much. Or I can go to the city government, and they're extremely cooperative and supportive of the Manchester Police Department. But then I can say, okay, I need all of these line items, whatever that number is a year, that you're now going to have to pass on to the taxpayer. So instead of using a drug dealer's ill-gotten gains, we're going to shift the burden on a taxpayer. It's just counterintuitive, and I just think it's bad policy. And I understand that there is this, there's something nefarious afoot with law enforcement. There may be some.
The reason I wanted to ask you that question is that it's a matter of balance, but I think that there's a very clear nexus between the source of that money and its use, plowing it back into law enforcement and preventing the kinds of cases that Mr. Ray's had to deal with personally and that she continues to deal with in her service. And I want to thank you for that. Ms. Hurley, I had a question for you you mentioned variations among states, and with colleagues and any professional affiliations that you may be a part of or networks, are there any states that seem to be a best practice in going about providing care back in their communities?
I'm most familiar with the New England area. I think that each state has a strength. Vermont with their, what they refer to as the hub and spoke model to access rural areas. They're doing a phenomenal job with that. I'm part of the faculty for the New England School of Addiction Studies, so I've worked with some of those physicians, and they've done a phenomenal job. I have to say that in Rhode Island, the governor's task force on opioid overdose prevention has brought together all of the, it's truly an interagency collaboration. Department of Health, Behavioral Health, hospitals, EDs, AG's office. She has 17 people on the committee, and they've done a tremendous job of creating 4 strategies, looking at dollars communally. So I believe as we move forward, that may be a very, very good model for addressing this. And it looks at, we've actually been looking at every single thing I think that's been noted here today.
Well, thank you. I want to thank all the witnesses. I want to thank Senator Ayotte for also continuing to demonstrate her interest in this important matter by sitting here, beginning the committee and ending the committee with us. This will conclude the meeting. The record will remain open for 1 week to provide additional information, potentially to respond to any questions that members who were here or who were not able to attend may have. Thank you all very much. God bless you. Meetings.